which is good. It has an average growth potential, but which is speeding up. And there are two things to take into account. There's a high level of innovation and a high level of impact in terms of regulations. When broken down by region, 91% of this market is concentrated in the United States, and then there's Europe, Russia, areas that are significantly growing, which are growing the most. Latin America, it says, is a market with growth potential because of intra-hospital infections. Safety. This is one of the first papers where I saw a reference to re-sterilization. It was a Chilean paper. They discussed 23 surgeries and they took pictures of the tip of the ureteroscope in disposable and reusable ureteroscopes. And clearly disposables, until one we use, sustained significant damage at the tip. Deflection was not altered, but in the conclusions, they do say that re-sterilization is a common practice, not very much documented in underdeveloped or developing countries. And this is one of the first where this is mentioned. This was a source of discussion, and look at the authors. This is a paper where at 11 centers throughout the world, basically India, Indonesia, Morocco, Russia, the first authors, none of them ever used re-sterilized equipment. And there was Dr. Samani, he was here until yesterday. And they analyzed their cases retrospectively, 2,183 patients, and the rates were quite similar to what was reported for reusable equipment. You see the figures there. This is a very interesting discussion. There you see the author's hands. They said that re-sterilization started many years ago, that is quite more frequent than what you might imagine. In this paper, they use this flash sterilization, which from what I understand is an autoclave vapor at 130 degrees. Here we use ethylene oxide at 60 degrees, trying to protect the equipment. And they had a 31% rate of retreatment. This may be due to the fact of having used equipment which was not all too satisfactory in terms of deflection or vision. They underscore the role of the FDA, the Joint Commission, and they suggest that there should be care in re-sterilization, written policies, and especially patients' approval. So this paper rocked the opinions because it was very much publicized. Dr. Gahard retweeted it. He said whether this is feasible, if it is controversial, and whether it can be done. We had this paper, we submitted at the World Congress in Korea, in the Neurology Association. It was a multicentric study, and where I had to stand there, I was quite cautious and afraid, so to speak, because I said, or I thought they were going to kill me. And the approach was the environmental one. It is not that it is least important. It is the most important thing, of course, but definitely what leads us to re-sterilizing is not environmental concerns. This was a prospective, observational, multicentric study. We have the Health Ministry's umbrella. It was seen by the hospital's ethics committee. So the ethical leg is unquestionable. And in 8 centers throughout the country, we brought together patients who, they opened the ureteroscope and used it. That was group 1. And yet another group where these same ureteroscopes were used once re-sterilized. We analyzed variables such as deflection, vision, and variables inherent to work itself. Deflection and vision were similar. There was a difference in stone size, but there was no difference in the stone-free rate and infection rate in patients operated on with a disposable first-use ureteroscope vis-a-vis a group of patients operated on with re-sterilized equipment. This there was Agrawal from India moderating the table. He loved it, and he said, it's very bold of you to present this paper because everyone does it, but no one is saying it and documenting it. And indeed, we are monitoring patients with him and an Israeli group to provide more say to these data conclusions. Instrument reprocessing did not appear to affect surgery efficacy or safety. Think of questions for later, and let's see the conclusions. Re-sterilization is common practice throughout the world. And when I say the world, I mean the world in general, not the world as we think, which is the USA and Europe. It is undocumented. There are no protocols in place, but I'm convinced, it's quite consistent that this be so. Why should it not be the case? Why is it so terrible if we re-sterilize reusable equipment? Reusable equipment is sterilized. Disposable equipment should be sterilized too, and I don't think this will bear a significant impact. But clearly, this will help us save money and resources. It will be more environmental friendly, but definitely we need to base this belief on publications. So I invite you to work. In 2 years, there will be the World Congress here in Argentina, and it will be very important to have strong data on this. And thanks for your attention. Excellent presentation. Thanks very much. Now let's move on with the agenda. Tiago Jota will speak about BMBH surgery in patients who have urinary problems. When we finish the presentations, let's open the Q&A. Start thinking the question.
Gracias, Mariano. Primeramente, me gustaría felicitar a la organización del evento y también congratular y agradecer a Pablo por la invitación y por siempre se dedicar tanto a endocrinología.
I would like to thank you all for the invitation. My job here is to try and speak Portuñol and speak slowly to explain what we find in these patients that will change our behavior. When we see the patient at the visit, their doubts about catheters are these. Do I have to undergo surgery now? Can I not solve it through medication? Will I be able to urinate normally afterwards? And surgery, is it high risk or not? Yes, but we have our doubts too. Which is the most effective procedure for this patient? To tell them certainly that they will urinate and fast, that they will not have the catheter for months, which is the safest procedure. Why do we have frailer and more elderly patients and who cannot withstand surgery with a higher bleeding risk? And how to manage this period? Do we use antibiotics? Do we not? Shall we change the catheter? So we'll try to answer our patients' doubts, but also our own. I found a patient like this, 74-year-old patient, retention-associated hematuria, 4 transfusions with 8 HB, 2 surgeries to evacuate clots, 1 open. The MRI showed 700-gram prostate. So the question I ask you all, we are treating a benign problem, but which hinders the patient's quality of life. So rationally speaking, the amount of tissue resected will change this variable. In this paper, we have patients who had acute or chronic urinary retention, uh, those who have the catheter for a long time, 70% acute retention, 30% chronic non-neurogenic retention. When they went surgery, 76% in the chronic retention group, and Lutz group, 87%, were able to urinate the day after the procedure. But if they cannot, we leave the catheter for 2 weeks, and they try to remove the catheter after 2 weeks. At month 3, we have a catheter-free rate of 98% in the acute retention group and in the chronic retention group with holmium laser enucleation. And if I remove all the tissue, 98% will spontaneously urinate. But if I try to compare with other techniques, like vaporization, for example, there is this study which compared both, and they even submitted these patients' urodynamics. And in the holmium group, 71% of patients had some degree of hypocontractility. So 70% may have some hypocontractility by removing tissue. So the removing tissue will be the best possibility. And here is the difference at month 3, catheter-free, 99% in the holmium vaporization group and 74% in the other group. So there is a response pending. By removing tissue, we have a 90% certainty that the patient will urinate spontaneously. But is it safe? Is there any difference between operating on a patient with or without retention? In the data bank, they assessed patients with traditional prostate resection, comparing risks. And these are the differences. Patients with retention have more symptoms after 3 months vis-a-vis those who do not have retention. There is a higher infection risk, serious infection risk, but septic shock and septicemia. And there is a higher bleeding risk, twice as much the risk of blood transfusion in patients with catheter compared to those without catheter, longer hospitalization periods, and higher costs as a result. And the same with enucleation, the same with HOLEP. There's no difference when we speak of hospitalization, bleeding, and infection, at least here. But it makes sense to think that we will have less bleeding when we perform enucleation. But does it make sense to say that there will be less infection rate? Of course not. So you have to take into account the infection risk and perform a safer like HOLEP. This study shows there is a difference between patients who had a short time on antibiotics, less than 3 days, and 1 day on average, vis-a-vis those who were a longer period on antibiotics before the surgery, 7 days, before and after. So there is a 7.5% difference and the risk of infection of the first 30 days. What I do is maintain antibiotics until surgery in patients on a catheter. I will ask you if you do the same, but that's the conclusion. Also, with a negative culture, do administer antibiotics 7 days before surgery. We may now tell our patients that there is a high probability that they will spontaneously urinate, but there's yet another question. They want to know whether the disease will come back. So the patients Google in the internet and say, I tell them, I'm going to offer you, I fear bleeding, so let's see whether this is the right choice in this scenario. We have this systematic review comparing these 5 studies, but look at the difference in the endpoint when removing the catheter, 70% in this vis-a-vis 100% in the other study. But in both, where they remove the catheter in all patients, they are small, with 10, 16 patients respectively. And look at the other one, We have patients with a residual of 100 ml. They are patients who, even on medication, who have an IPSS of 4. There is discrepancy in results. This other study showed that patients have 30 days to remove the catheter after the procedure. That is what we have to talk about with the patients. 30% of patients who have no catheter, who are just on medication with the detrusor, and there's 70% of them which may be left without the catheters, but another 30% will have to maintain the catheter. These data we have to share with our patients to help them with their decision. And same thing, patients who do urodynamics before surgery, 40% of patients, 30% even if wrong, and 28% non-obstructed in patients with retention and patients who have some degree of damage. And what happens with enucleation? The Peter Billing study shows after enucleation, you need just the maximum flow of 20 for proper normal urination. So I don't need much pressure to urinate after this kind of surgery. Same the McCormick study, the 19 patients with acontractility before surgery, and after 24 months, only one of these patients still was using a catheter to remove the urine residue. And the difference, the detrusor pressure maximum was 25. So after enucleation, ureteral retention is so low that we need less contraction.
And the last message is this study published in the Journal of Urology that shows data of many years in New York State, patients that underwent resection or vaporization. The risk of patient of having a failure, a new catheter or new surgery, is that the patient has more than 2 retentions in his life. Those have a higher risk of a failure of the surgery. But those who have a catheter, they wait for 6 months. They have a hazard ratio of 2.2 of a risk of for failure in the surgery. And what happened with our patients, he was subjected to a HOLEP without incident. The adenoma was removed with a cystostomy, and he was discharged in the second post-op, and no transfusion was needed in this period. So this shows that there is safety and there is effectiveness above 90%, even in large prostates and in patients with a detrusor that is not so well. So the take-home message is you have to infer the degree in which the bladder is not functional, and either if they have more than 2 problems, then it's a problem to de-obstruct. Have at least 7-day antibiotics, and if you are enucleating, then the area remains cleaner. You have to be more patient when you test the patient in order to remove the catheter. 30% don't urinate the first day, but after 1 month, 90% are. EEP may guarantee higher safety and efficacy in the long term, and you shouldn't wait for the patient to have several retentions before operating, or wait 6 or 7 months for the surgery. Thank you. Excellent presentation, Tiago. Thank you. And now, Mariano Castillo from Cuba will discuss how do we do endourology with limited resources. Mariano, good morning, everybody. I wish to thank Dr. Pablo Contreras and Dr. Gonzalo for the invitation to this event and offer the opportunity to be once again in Argentina. When Pablo asked me to discuss this topic, I thought a lot about how to do it, and I thought that the presentation of clinical cases and see how we solve them was a possibility to present this to you. We in Cuba do endourology since the first lithotripsy center was inaugurated in my country in 1986. We created a multidisciplinary group to generalize these methods in the country, and we had an HM3 machine, and we purchased all the instrument for endourology and extracorporeal lithotripsy. We have treated from then to date 40,000 patients, more than 40,000 patients in different treatments for lithiasis. Initially, we had an update, a systematic update of our instruments, but afterwards, the problems we have with the country's economy, we lost the possibility of updating, and I can tell you that now we only have available endoscopic instruments, semi-rigid for ureteroscopy, a set of laparoscopy, lithotripsy equipment, and our CR. We do not have ureteroscopy forceps. We have some instruments that we made. We don't have enough disposable elements, and we don't have enough flexible and laser devices. So we have to try and solve the problems with our patients as we can. The purpose is this, to show the residents and especially the young specialists that it is possible to practice endourology even if you don't have all the resources, the most advanced ones, and even with a deficit of resources that may be basic. And as I was saying, I will present cases so that you can see how we solved the difficulties. The first case is a male, 41 years of age, without chronic or urologic diseases, and with lab studies and negative urine test, he came because he had a nephritic coli. We got a CT, no contrast, and what I want you to see are the images, especially the youngest ones. Look at the characteristics of the location of the stone. Look at the axial view. If you look at it carefully, that image that you see there represents that the lithiasis is behind the vena cava. So there we suspected that the patient had a ureteral lithiasis in a retrocaval ureter. You see here the nice view. The ureter goes behind the vena cava. And and we corroborated it with a reconstruction, and we see perfectly well our diagnosis. It was lithiasis in the retrocavus ureter without a laser and without a extracorporeal lithotripsy machine. So those of you who have other elements would do a flexible ureteroscopy with laser, and that's that. But what we did, we thought since we have the ureteroscope, let's do a semi-rigid ureteroscopy, and we hoped that we could get to the stone very carefully because the cava was there, and that we could fragment it there. We thought that maybe there would be some retropulsion of the stone, and what happened was that we did the retrograde ureteroscopy. You see the stone, that it was impacted with the pneumatic lithotripsy, and the stone moved to the middle calyx. Then we created a percutaneous tract. The images are not the same. We went in through the middle calyx, and the stone went to the junction, and the semi-rigid ureteroscope, we did a mini percutaneous. It was a 14 French, and we were very careful, and we did well. And then we placed a double J's, and we left him tubeless, no percutaneous nephrostomy. He underwent the surgery 1 year ago, and he's doing well. In this case, those of us who taught us about retrocavus stone said different things than what we saw. But in to comment. This case is 71-year-old, a male who had a prostatic adenocarcinoma and morbid obesity. Look here. If we had had a laser, high-power laser, this could have been solved very well, but look at the number of maneuvers we had to perform in order to be able to get percutaneously, to do a percutaneous procedure, and we succeeded. So ideally, one should have all the equipment, instruments, and necessary and updated accessories. But because of the reality in Latin America, many countries cannot have all that. So you can perform endourology if you select the cases well, you have creativity and experience in order to find alternatives, and if you are passionate about endourology in order to provide treatment to our patients. Thank you.
Muchísimas gracias, Mariano.
Thank you, Mariano. Thank you. Excellent. Well, these are different realities. Disposable ureteroscope that we have a lot, and we have to be careful with the carbon footprint, to a reality in that we have to use the instruments we have available to solve our patients' pathologies, the stones that the patients have. I think that is a trend to look for. I mean, beyond the fact that in Latin America we cannot have everything, we should be wise enough and creative to solve these. Questions about the presentation? Tiago, Mariano, if you want to come up, then people can ask questions. So you can sit here. Now, open to questions. Good morning. For Tiago, I would like to know about the case you presented of the giant case, how long the surgery took, and how did the urethra remain after so much time? And the other question is, do you use antibiotics and for how long after a prostatic surgery, no matter which? Well, the enucleation took 1 hour, the one of 700 gram. You start morcellizing. We spent like 30 minutes morcellizing because this tissue was hard. So the patient had a cystotomy 2 weeks before they had opened the there, and it took 1 hour and a half with resectoscope. And then I opened the patient to remove the adenoma. That was open surgery. And we used the laser for coagulation. And the patient with a negative culture, the patient had 7 days of antibiotic. I learned like that from my mentor. He did that with all the patients. So I had one case of a serious infection, and that's why I give my patients 7-day antibiotics always. And if I remove the catheter, no more antibiotics. I'm sorry, but medicine has become a business, and the people who are the least benefited are the doctors. Analyzing the history for 40 years that I have been a physician, I think that these infectious processes were not worse 30 years when we sterilized everything. We would reuse double J's. We would wash them, sterilize them, and reuse them. We should reanalyze this because now consumerism is encouraged. The hospitals, I mean, if you reuse, then the certification is removed. So we need to do things to solve patients' problems, as Mariano has shown us. I want to congratulate you on your presentations. Dr. Tiago, in those cases when patients have such a large prostate, do you use a longer device? Is it difficult to reach it? Because with that volume, sometimes it is difficult to get to the end of the prostate. Do you have any special equipment? Yeah, this is a resectoscope XL that is longer and it's better but sometimes the difficulty is not to get to the neck, but to bend the anterior aspect. And this is a case of, I had a patient with 900 gram, and then I talk to the patient, especially if the patient is obese, and I say that I will have to do something to get to the neck. But here we could do everything through the urethra. And it is not very expensive, this device, because we don't speak about prices. It's quite expensive if you are going to perform just 1 or 2 surgeries a year. So you have to consider a suprapubic incision and a perineal access to get to the prostate, maybe an open surgery could be considered, yes. The problem is bleeding, because if I'm enucleating, I'm controlling bleeding all the time. But if I try to do an open surgery, sometimes my finger doesn't get to the apex, and there is a lot of bleeding. If I remove the prostate, it bleeds so much that sometimes you cannot control it. And if I'm enucleating, I'm controlling bleeding all the time. So it's safer for the patient. I think that once you get over your learning curve, enucleation, even in large prostates, is convenient, is preferable than an open surgery. Even if we think, well, if it's large, I'll do it open, but precisely because of that, of bleeding. And another thing is that they have long material because they are Brazilian and they are used to it. We in Argentina use the plain ones.
Perfecto.
Another comment for Mariano. 20 years ago, when I went back to the residency and to work in Santiago del Estero, and it was similar, and there you can have to manage. A question for Mariano. When do you decide to use the lumboscopic approach or transperitoneal? Do you always do it lumboscopically? Because removing that stone when you have no more time, well, it's fearful. How do you do? Well, the surgical time, our average, we were working with a basic laparoscopy set. We take between 2.5 and 3 hours for the laparoscopic procedure. Here, we have in our working protocol the center is laparoscopy. We prefer lumboscopic surgery because of lithiasis, infection. We think it's safer to approach lumboscopically, and that's what we do usually, except when we have no alternative in that type of surgery. In our protocol, the surgery, that surgery is indicated in patients like that lady that has a large stone, especially in the pelvis, and without much invasion of the calyces, that the pelvis is extrarenal, and especially if there is a history of urinary infection, in order to not to do percutaneous nephrolithotomy, perforating the parenchyma, the rupture of the stone, the release of germs in that maneuver. So we prefer in those cases to open and remove, just as in an open surgery, and not perforate the parenchyma. That is the most important indication for lumboscopic pyelolithotomy. For Dr. Tiago, what is the diameter of the extra long equipment, and if all the brands produce it? Well, as far as I know, the extra long 26 has a laser element and polar mode, not bipolar. But as far as I know, only RZ produces that. I have a question about the disposable ureteroscope. Do you think there is a maximum number of reuses? What do you think we should do? Well, here in Argentina, the resolution of the ministry allows 3 re-sterilizations, that is 4 uses in all. And actually, not only the ministry, but the HMOs and the insurance company pay 1/3 per patient because they are endorsing that we are going to reuse the equipment up to 3 times. And in 3 uses, the ureteroscope works still well. Well, that's why we ran the survey the before the surgery. You control the vision, you control everything, and if the equipment is not working well, well, then we have to change it, because sometimes we want to use the defective equipment all the same, and what happened is that you need more retreatments, a lower stone-free rate. We haven't had serious complications, and you say, well, maybe something will happen later on. Well, it hasn't happened, but up to 3 times is endorsed by the ministry. And I think it also has to do with the fact that you have the possibility of using multiple brands in Chile. You can use all the ones that you have in the market, but here in Argentina, it has to overcome the UNMAT, and we do not have the same number of equipments. And there are certain differences between the duration of different equipment in the reuse. Sometimes you see that they can stand 3 or 4 uses without any problem, but there are others which are not functioning the same way the second time. There are also equipment that have a certain time to be used, others that do not. Tiago, do you have an experience in such large adenomas to do the morcellation to a certain moment, then stop with a catheter and come the next day back in? Then the adenoma, according to someone, is very soft. I think it's a possibility. 900 was private, so taking the patient back to the OR would be very expensive. But in this case, I decided to solve everything in one step. In Brazil, I don't know if they accept the idea of just leaving the adenoma and come back in the next day. I think it's better for the patient to make advantage that and remove the adenoma with a morcellation rather than taking the patient back to the OR the next day. Cesar Escofone describes that when the tissue is a bit more elastic, or the morcellator is malfunctioning, he comes back 2 days later and the tissue is very soft. It's a private hospital and we don't do it. It happened to us because the knives have been used many times, and we left the patient. We came back then, but the tissue wasn't soft. It happened that to us with the old morcellator. Now with the new one, it doesn't happen so much, but with the old ones, it did happen. Dr. Tiago, in those patients with a high risk of post-surgery retention, any medical treatment or small cystostomy so as not to require a permanent catheter? For the most fragile elderly patients, I live with a cystotomy. If there is a possibility for a catheterism, I speak with the patient before the surgery and maybe they will have to have an intermittent catheter, but I generally try to remove the catheter the next day. But if there's problem with but if the patients are very old, well, if there is a doubt, for instance, a retention of 2 liters, I always leave a cystostomy. When the patient has retention, do you prefer a laser? Do you prefer pulse? I prefer Holmium because of the speed, but with others, I use it with patients that are anticoagulated. I use thulium fiber because of the thermal capacity, but I like to use Holmium for large prostates and retention. I like it more because of the speed. Well, hello, dear. In these cases, anecdotal cases of such large prostates, do you consider the option of sending the patient for a robotic surgery? I mean, less operating time, there is no need to morcellate, you just remove the piece. So in your menu, do you have that as a possibility? Well, before the surgery, that surgery of the large prostate, I found an article that they did the HOLEP for the first half and then robotic surgery for the other half because in pieces that are more than 500 gram, it's difficult, but in the two I had that were over 500 grams, the facility to enucleate was there, and we can get a better apex. I think that the enucleation is favorable in these patients, and also the incisions will be much smaller. And about opening the perineal urethra is not a good option for the patient. But before, with the resection, it was considered a surgery that was protecting the urethra. I mean, the perineal approach, because we are protecting the urethra because we do a longitudinal cut and then the resectoscope is not there. I don't know whether robotic takes less time than an enucleation. I don't know. I think that it depends on the learning curve at the time, in what area you are. But now with the new morcellators, I think things are different, just like robotic. From the post from the point of view of cost, robotic is a much higher cost than the one we have with an enucleation. Thank you. Well, I don't know how we are doing with time, but I think we can continue.
Any other comment, question? Tiago, concerning patients with such large prostates, the use of tranexamic acid, is it a routine practice? In which patients you never use it? Did things change by using it? I never use it. There is a study showing there is no difference in bleeding risk. And it's somehow subjective. In those patients where I use tranexamic acid, clots are so hard that you sometimes have to resect them and reoperate these patients. That's why we don't use it. No, we never do, but we to use a morcellator to remove clots, but not with tranexamic acid. Pablo? And in these patients with such a large prostate, do you use the bipolar for cauterization? Yes, in every case. I learned with everyone in South America does in the same in South America. And even in also large prostates, I use the bipolar because it's thermal. There's no pulse, so it provides the ease of hemostasis per area. You cannot go into each vessel, so there is an advantage using the bipolar. I always have it handy, irrespective of volume. Yes, irrespective of volume. Well, in smaller prostates, it's not that necessary, but the idea of sending the patient home early, as Mariano does, I think there the bipolar is of great help in this scenario. Mariano is more seasoned to tell us about this. Yes, this is a discussion we always have. When we started using laser alone because the concept was if I use laser, I have to use laser, nothing else. But the reality is that when we started using the bipolar, we noticed that final hemostasis times were faster. I'm not saying there won't be good hemostasis with the laser, but it allows having this as an outpatient surgery. 80% are ambulatory surgeries. Patients can go home, and from irritation symptoms, the old concept that people have in mind, that if I use the bipolar, they will have more irritation symptoms, that doesn't change anything in terms of the patient. So that did not change us. Horatio, one question. Where do you perform a prior urodynamic study in a patient on a catheter where you suspect hypocontractility? Does it make sense doing it before surgery, or do you simply operate on them and then you simply tell them that there may be retention? But you don't verify it beforehand? Well, I use the upstream study, which shows that in traditional patients, urodynamics does not change the patient's path. What the patient will be like after surgery, performing urodynamics or not. But we need to have a discussion with the patient, so they will have more difficulties after surgery. This is what I do with patients where there is the diagnosis of small prostates, or in patients where there are some neurological issues, I do so. But in 40-year-old patients, I perform urodynamics and cytoscopy. In traditional patients with retention, I speak of the possibility of hypocontractility, and I tell them that urodynamics will not change my behavior. Even with contractility, I will offer enucleation. That's why patients often times prefer not to go for it. When you use the thulium fiber for nucleation, do you use the bipolar as well? Because I only have the thulium fiber and do not use the bipolar one. Fiberglass can be left continuous. That's why
Con fiber 12 eu uso
with
mucho menos
fiberglass I use
el bipolar.
the bipolar far less.
Porque es térmico como el bipolar.
Eh,
Puede mantener en continuo.
It's thermal like the bipolar.
Principalmente del cuello.
Especially you can have hemostasia in the neck, but in larger prostates I end up using holmium. The problem with thulium fiber is that you don't, the dissection is the same as with holmium, so irrespective of the fact that you can enucleate, exactly, that's what I mean. Enucleation with thulium fiber is not the same as the holmium enucleation. That's why, I mean, it's the same as Jose Perez Carral did back in 2017 when I learned the technique. It's 2023, and I realized I knew how to do it. I watched all the patients again. It can be done. What I mean is you may enucleate with whatever you have, but the idea is to enucleate, and it's okay. I am not against using bipolar or fiber. I say there are different energies for nucleation. There are two today which are quite more similar, and then the others where you can enucleate nonetheless. That's the point. With new thulium, do you use the bipolar nonetheless? I did both things with the pulsated thulium. The reality is that you have a first hemostasis step quite similar to what happens with hormone modulation. That's the feeling. And you have the feeling that you might not use it, but my habit is that I use it. So I mean, I'm old. I am recognized because of how old I am. It's difficult to engage in certain changes. I mean, brain plasticity is not that easy. That's the problem. Coming out of the comfort zone, and we send the patients home with the catheter the same day, but it's a mindset. I have to change it. I know. Don't kill me, Mariano. Mariano, we are speaking of enucleating with robotics, holmium laser, thulium, pulsated thulium, bipolar. What do you do there? Prostate above or below 80? What do you do with those patients? In Cuba, as of today, no one performs whole lep. And we use mostly RTU, bipolar, monopolar, open surgery, and the laparoscopic surgery. Laparoscopic prostatectomy in prostatic hyperplasia. That's what we do. RTU, monopolar, is still important because of equipment issues. Some hospitals like ours and others in Havana have the bipolar one, and they perform bipolar surgery. In the endoscopic surgery center, they perform laparoscopic surgery for large prostates, and that's what we have as yet. Well, but you solve the issue. That's what matters, solving the obstruction. Hugo, one last question. A question for the panel at large. Do you have any experience in Latin America, since you are talking about the use of botulinic toxin? Yes. Not necessarily in large prostates. We have even done it in small ones because they are the ones that are that they have a larger muscular fibrous component, and that you detect in the patient when receiving them at the office. They have significant symptoms, and you continue doing the case history and supplementary studies, and you realize they are abstracted, and in the end, that's uh, compensation, the compensation hyperactivity phase. We have to avoid the trigon. I have even placed two botulinum toxin vials. We have used the 200 units. In a patient, we had to use two. We have to avoid the trigon, go above the lateral meatus, and have the application needle at hand, and you can apply it via the nephroscope with no problem, and the patient will have no storage symptoms following surgery, and quality of life will improve significantly because you will be resolving both problems, the obstruction and the storage. Because of time, we're going to move on with the program. Thanks very much, Horatio, Mariano, and Tiago, for your excellent presentations.
Bueno, buenos días.
Good
Continuando con el
morning.
programa, vamos a empezar
Now
la
we will
sesión de
start
enucleación.
with the
Invitamos
enucleation
a
session.
Rodrigo Melón,
We invite Rodrigo
Pablo
Belogno
Valladares,
and Pablo Valladares, the
e iniciamos
moderators,
con
and we
una
will
charla de cómo
start
empezar a hacer
with a talk
enucleación
on how
que
to
va a hablar
perform
el doctor
enucleation
Nicolás Villasante, que es el
by
jefe de
Dr.
sección de hiperplasia
Villasante,
del
head
Hospital
of
Nuclear.
the benign
Buenos días
hyperplasia
a
from the
todos.
German hospital.
Gracias por
Good
su
morning to you
presencia.
all.
Y vamos a empezar entonces
Thanks for
con
your
el comienzo,
presence.
que es
Let's start by the very beginning,
cómo empezar a nuclear. Entonces yo creo
how
que
to start
lo
enucleating.
fundamental es tener la
What is
motivación.
fundamental is having the
¿Por qué? Porque
motivation.
vamos a abandonar
Why?
quizás
Because we
un
will
camino que veníamos
abandon a
quizás
path
muy tranquilo,
that we
haciendo
were
quizás
taking,
RTU o
doing
vaporizadores
RTU or
ciertas
prostatic
cirugías abiertas para
vaporization or
próstatas
certain open
de mayor
surgeries
tamaño para
for
pasar
larger
a
prostates
un
and
terreno
move
en un
to
principio desconocido que vamos a ver ahora
unknown
que
land.
no es del todo sencillo
And we
cuando
will
inicia.
know it is not that easy when
Muchas
you
veces
start
después
engaging
de que
in
esta
this path.
cirugía vamos a estar
After these
agotados,
surgeries, we'll be
algunos se van a
tired,
plantear si
exhausted. Some of you
tiene
will
sentido y vamos a decir, bueno, hasta acá
question
llego,
whether
basta
it
de
makes sense
continuar
and
con esta cirugía que
think of
no tiene
not
lugar.
performing
Entonces
these prolonged surgeries
vamos a
any
ver que
longer.
tenemos que lograr hacer una curva de aprendizaje
We
lo más
have to
sencilla posible. Ya en
have
el
as
año
simple as possible learning
96,
curve.
Peter Gill entonces
Back
presenta
in
sus
96, Peter Gill
las
presented
cirugías prostáticas con láser
prostatic
Holmium,
surgeries with Holmium laser,
vemos que desde
and we
ese
see
momento
that
hasta
since
nuestros días,
then
todos los
until
años
the
hay
present date,
muchas,
there
muchos
are
artículos sobre
many
curva de
papers
aprendizaje.
published
Curva de
every day on the
aprendizaje
learning curve,
comparando diferentes enucleaciones,
comparing
curva de
different
aprendizaje comparando
enucleations,
enucleaciones
learning curve
versus otro tipo
comparing
de cirugías
enucleation
como la
versus other
RTU,
surgeries such as
etc.
RTU,
Yo creo
etc.
que
So
la curva de aprendizaje hoy es
the
el
learning
principal
curve
obstáculo
today
para
is the
que
main
se
obstacle
generalice la enucleación
for
endoscópica de la próstata
endoscopic
para todos,
enucleation
sabiendo los
becoming common
muy buenos
practice,
resultados que tenemos, ¿no?
even
con
knowing
esta
what
técnica.
good results we have
Entonces
with
la
this
idea es
technique.
intentar hacer
The
una curva
idea
de
is to
aprendizaje lo
try
más
and have a
amigable posible, entonces
or
que sea
as
más
friendly
como la
a
amarilla, es decir, que
learning
lo haga lo
curve
antes
as possible,
posible,
like the yellow
con el
one,
menor número de casos, logremos
as soon
una
as possible with
experticia
a smaller
rápida
number
y
of
hacer la
cases,
cirugía
gain
cómoda
expertise
y
that will
amigablemente.
allow us to perform
Eh,
a
pero
surgeon-friendly,
primero siempre
comfortable
nos planteamos cuando uno va a iniciar esto, bueno, hay una
practice.
mejor técnica para
Is there a better
iniciarse en la
technique to
enucleación, es
become
mejor hacer
initiated in
una
enucleation? Is
cirugía
it better
por
to do surgery
en bloque, hacer
in
prolobes,
block
hacer
or per
bilobar,
lobe,
trilobar, qué tipo de
bilobe,
energía quizás es
trilobe?
mejor para
What kind
iniciar,
of energy is better?
Holmium,
Holmium,
energía bipolar.
bipolar
Yo creo que
energy.
la respuesta a esto
The
es
answer to this
uno tiene que utilizar la
is
energía.
that you have to
A ver, si uno
use,
puede
I
adquirir
mean,
un Holmium de alta
if
potencia,
you can
fantástico.
buy
Hoy en
a
día
high power
tiene
Holmium,
algunas
great.
ventajas sobre otros
Today it
métodos, pero yo
has
creo que hay
some
que
advantage
iniciar
over
con la
other
energía que uno
methods, but you
tiene.
have to start with the energy you have at hand.
Nosotros, de hecho, en el Hospital
Indeed, we at the German hospital had the green laser equipment item, and we said, well, let's give it a second twist. And we started nucleating with green laser. The people from Trenkelauken are present here, and they have great expertise using bipolar laser, and they have had good results too. So you can start with the energy you have at hand, and it's proven that results are very good irrespective of the technique that you use. Because as Thomas Kramer said, enucleation is enucleation. This was also said by Mariano. You have to develop the enucleation technique and be familiar with them, whichever the energy or the different techniques that we are familiar with. You may have very good enucleation surgeries. When you have to select the cases, when you start in this learning curve, it's important to select the cases. We have to see prostate features, size, whether the lobes are small, medium, large. But let us not forget that around the prostate there is a patient. When you start engaging in this learning curve, you have to see what patient you have before you. When you start the learning curve, probably there are prolonged surgeries with more bleeding. Maybe you have to move to another method. So you have to know what patient you have before you and whether the patient will withstand the procedure when you start the learning curve, whether the patient will withstand a 3-4 hour surgery. The prostate is ideal for enucleation, but the patient is not ideal. So when you're starting, it's better perhaps to have a technique that you know uh, will be safer for the patient, a non-enucleation technique. What do the guidelines tell us? When there's an indication of enucleation, 70 to 80 gram prostate and larger prostates, but within that size range, is there any ideal one to start enucleation and this learning curve? What do we know today? Small prostates are less vascularized, but have a less clear nucleation plane vis-a-vis larger prostates with a more defined plane, but where it is difficult to maintain endoscopic vision, and you get lost when you have to operate a large prostate and you're starting the learning curve. And looking at different studies, average volumes in these papers that analyze the learning curve are 50 to 90 grams. And with those prostatic volumes in those learning curve studies, they are safe in terms of complication profile. Also, we know that other studies have shown that the average efficacy rate is 0.32 to 1 gram per minute. What does this mean? For example, if you are operating an 80-gram prostate and you're in that learning curve, where the enucleation efficacy will be 0.32 grams per minute, you will take 4.5 hours. So you have to assess that too. And also we know that up to 80 grams, you may easily perform transurethral prostate removal with bipolar. This may be arguable, subjective, but a good size to start enucleating is between 40 and 80 grams. And maybe it is advisable to use size range, prostate from 40 to 60, then when you have a given number of cases, to move towards a little bit larger prostates, as you see on slide, and so on and so forth, until you feel certain with a certain size, and then yes, move to a larger size. Some fundamental concept when you start enucleating, you must always have the bipolar, maybe not on the table, but handy, because you may need it at any time, either because there is a bleeding situation that you cannot manage with the elements you have at hand with the laser, or because at some point you prefer to continue the procedure and transform it into a transurethral resection. This is another key concept. You need to have a mentor. Who is a mentor? A person who is seasoned, who guides another one to realize his personal and professional goals. With the mentor, the learning curve will be shorter, and above all, it will decrease complications during the procedure, which is something that you are afraid of. That's the time where you quit using the technique and end up going back to the traditional surgery. This study, for example, saw that 33.3% of surgeons who had no mentor abandoned the program because of the complication rate during the learning curve. The mentor is absolutely necessary as well, and we have to, you seem to recommend the instruments. Sometimes you ask industry, I want to start enucleating, what do I need? And maybe the company sends everything. And there the mentor or seasoned surgeon will say, well, I tried this, I have this other thing, and see what the reality is when you're starting enucleation. Get adapted to the instruments, and in this case, the mentor's recommendation is of the essence. There are programs, training programs with mentors that are defined. This is a program by Thomas Kerr, and basically it consists in having a mentor, having courses, and once these mentors go to the site where the mentorship takes place to perform the first cases, and subsequently the patient should continue on his own. In that program in particular, after 20 cases, the mentor came back, and so on and so forth, until the student has significant experience and becomes a mentor, and increase therefore the number of people on which enucleation is performed. There are simulators, even 3D printers. Others are simulators like the one here at the exhibit, which may be useful to when you start the learning curve. As by way of conclusion, the motivation is of the essence. You do not have to get frustrated. You have to go step by step rather than take leaps, risk anything. It is essential to have a mentor. As we said, choose the cases. And bipolar, I always say, you must have it handy. And above all, have a team that will accompany you in this tortuous path, a motivated team that will help us develop our learning curve. Thanks very much.
Nico,
Sí.
vos ahora tenés que empezar de vuelta la curva.
You have to start the curve again now. Let's say, yes, I would do it. I recognize that with Francisco, we started the curve in the hospital, and I think that's also very good. I told Francisco when I was about to start, I asked him to do it with me and have a co-equiper when you undertake this learning curve. And it's also the experience of two persons. Many times we were together in the OR, one was operating and the other one was there just uh, encouraging, and we had a mentor. I had one in Barcelona. He came for the first cases here to Buenos Aires. And I think that the mentor should be someone that can give you feedback, not just one of the big guys. And so maybe you should get a mentor whom you can send a message or you can call about a case, or this is happening with the instruments, what happened to you, are you doing something new? I think all this is important, and when you start the learning curve, you should watch videos, especially your own and those of experts, and your own are very important because during the procedure you don't realize certain mistakes that you make, you don't find the right planes, for instance, and when you watch the videos, you see things that are improving and the things that you're doing wrongly. And I mean, you can do it when you're watching the video and not when you are in the OR and you just want to finish. I wanted to congratulate you on the presentation, very educational. And the thing is that you should consider this thing of frustration. I compare it many times with when you start playing golf and you are already older and you go and you play well and you think you're good, and then the next time you cannot even touch the ball. So sometimes you go there in, you find the plane, you find the right prostate, you resect, and you are very happy. And then you move on to the next level. And you have bleeding, you don't find the plane. I think that in order to prevent frustration, the support of your mentor is very important, or watch videos and know that you can do things and what is the technique that I should use. You oftentimes see enucleations, very nice, a block, and maybe the road is to start little by little and have a way out when you think, when things get difficult, because otherwise what we do is we block the OR because people think that you are going to operate on a prostate and you'll take 4 hours and everybody is looking with a horrible face at you. So to avoid all that and one's own frustration, I think that you have to take all the elements into account for this practice, which is so good, but we need to succeed. Another thing that is important when you start, it's better to perform 2 surgeries in a day if you are not in a high volume center. Maybe it's better to do 2 surgeries in one day than to do one every 10 days. I think that in the second one, you can see what the difficulties of the first one were, and so the second one is much better than the first many times. So maybe you should have more cases in a week than having 2 cases in 10 days. Congratulations on your presentations. I also think that the time dimension is very important in all the publications. All the publications speak of cases done, but in very few analyze what the time is that students need to complete the cases. I am from Germany, and now I know the European system, and I have seen some centers here, and the situation is totally different. When I do something, I see 5 surgeons, and I can watch 5 surgeons in one day, and what is its effect. And I did sometimes, and I said we are going to do the enucleation, and each of you has a lobe, so at least in one prostate, at least 2 surgeons can participate. So we need to bear in mind the time element, how many weeks or months we need to complete the cases that appear in the nice publications, but we know that science doesn't always reflect reality. I wanted to say something about that. First of all, thank you for having this space so that we can discuss something that is very new for many. It's very time consuming and labor consuming and other things. First, the equipment, the team is very important. We need an ethicist, we need a head of the service to cooperate, we need to know that this is a project of the whole service, and this is not something that you will get results in 1 or 2 months. You'll start by seeing the results at 4 or 5 months when patient satisfaction is complete and the team satisfaction is complete as well. And with respect to the learning curve, I have to go through the curve practically alone. I with Gomez Sancha, I saw the evolution of the green laser to the anatomic removal of the prostate, vaporizing in the mid globe, and then the others, and then when they started with the enucleation with green laser. And then we saw in Uruguay, but also in Spain, we went to Bulgaria with him, and we came back and we had a 30-watt laser, and that was that. And so what could you do? Well, I'm not going to tell you that you can approach a prostate with a 30-watt laser, but something you can do. And he said, there will be a German guy who will invent a loop that will revolutionize everything. That was Thomas Herman, and I saw the presentation, and we created a technique, our own technique with that loop, and it is really labor consuming, but it is really important, and I thank you for having this opportunity and for having this Q&A that is something that we can all share and learn.
Bueno, continuando con el tópico,
Well, now,
invitamos al doctor Tomás Taili,
Dr.
que va a
Thomas
hablar de cuáles fueron
Tiley,
mis errores
and
durante este
will
proceso.
speak
También
about
vamos a moderar al
my
doctor Tiago Jota
mistakes.
y al
Dr.
doctor
Tiago
Juan Pablo
Jota will
Caprini.
be moderators, and Dr. Caprini will also be the moderator.
Good morning. Thanks once again to the organizations for having me here. You all just heard a great talk by Nicholas, and in essence, I did the exact opposite. So that's my mistake, that's my talk, thank you. I almost was in the 33% that quit because of frustration. We've heard a lot about frustration, and there's a ton of frustration if you start with HOLEP. So what were my mistakes with starting HOLEP? And I'm not going to talk about different laser settings or different surgical approaches, because if you look at every different laser setting or every different surgical approach, it is the best approach for somebody doing it. So I'm not going to talk about what my preferred approach is or my preferred laser settings, because they're different for everyone and you have to find your own. But these are my disclosures. What I will talk about is what I did wrong when starting. Like we've learned already, and I showed yesterday in my talk, there's a lot of learning curves that have been published. But if you look at those, and this is what's quite often reported, those novice surgeons are not always completely novice. They've went through dry labs, wet labs. They went to hands-on course, like the model, the mentor model that was published by Davao and Thomas Herman. I think that's great. But what was my experience before going into HOLEP? Well, I did a 2-year fellowship in which I did 0 prostate enucleations. I had over 500 TURPs, like single surgeon. I had over 1,000 laser procedures, so I thought I can handle a laser, it's fine. And I did about 30 bipolar enucleations, which I really liked. I went to a course once, I saw a guy do it, and I thought I can do this too. I didn't have the special Herman loop, but I just had the regular loop, and I started doing enucleations. It's fun. You can find the plane, and then you enucleate most of it, and then you resect the tissue that's enucleated, but it's still attached at two spots, because I didn't have a morcellator. And I thought, everything's going to be just fine. I can do HOLEP. It's okay. it's not. So how I started, my hospital acquired a high-power holmium YAG laser, and that came with a morcellator inside of the holmium laser, which means that I needed more equipment because now I think, okay, let's start HOLEP. I needed different HOLEP sets, and I didn't know which one to get, so I had to listen with my colleagues, which do you use, and what do you think is best, and so on. I also needed a morcellator scope, which I didn't have because I don't do big track PCNLs. I needed a morcellator handle because that didn't come with the package. And I had to wait for that for quite a while. I got the laser August 2019, and I couldn't start. I could go to courses, but I thought if I'm going to go to courses, I want to be able to start right away after going to a course. So I need to have that equipment. I don't go to a course and then wait 9 more months to do a procedure. So I'm going to wait with that. And then COVID happened. And starting mid-COVID, I can tell you, is a bad idea. Because like I showed in what you need to get training is you need to get trained before you start a procedure. It's what I wanted to do, but mid-COVID, there's no hands-on available. It's impossible. There's no workshops. And visiting a key opinion leader is super, super difficult. I applied multiple times, and then, ooh, what do you know? Another COVID surge, it's canceled. And then 2 months later, yeah, it'll be fine. 3 weeks before, it's canceled. So visiting a key opinion leader and learning from them was super difficult. And then let's see about getting started with HOLEP. Once you visit a key opinion leader, BPH, you couldn't do BPH because the triage said BPH is not an important procedure to do during COVID. And if you see what the forecasting was for future urology practice during or early after COVID, we see, well, BPH and all the guidelines agreed, or all the associations agreed, elective surgery should be delayed and is not something to do during COVID because you can be doing a procedure for a patient that can be helped differently. This is not urgent. This was impacting BPH procedures globally, and these are 2 papers that said, okay, there's a 20% decrease in BPH procedures. And I thought, wow, 20%, that's not that bad. So if you do 100 HOLEPs here, now you can still do 80. I thought that's fairly okay. But in fact, if you look at this paper, this probably more represents what I was doing. And they said, what's the lowest priority for procedures? And BPH was 60% responded by all the people who were surveyed. 60% said BPH is the lowest priority of procedures. And 86% said elective procedures for benign conditions are lowest priority. So that's BPH. I'm an endourologist, and patients who don't have acute kidney injury or don't have a septic stone, they're BPH patients. And the other patients are non-muscle invasive bladder cancer, and they need treatment. So starting mid-COVID is a bad idea, not only because prioritization said no BPH, also personnel, OR personnel, they're reallocated to non-surgical wards. So the OR theaters are reserved for urgent or semi-urgent procedures, cancer, obstructed stones with kidney renal insufficiency, and so on. So BPH, non-elective, it's on hold. About that, we were talking about how much time it takes for you to go through the learning curve. The surgical load is going to be very, very low. So if you need 100 cases, it's going to take you 10 years at this pace. So this really delays your surgical, your learning curve. So how about that learning curve? It says that experienced urologists, novices in HOLEP are mentored for 20 cases. Great. Try getting a mentorship during COVID. It's impossible. And if you need about 100 cases, and this learning curve showed us, and it was on your slides as well, this is a very honest data. You need about, even after 500 cases, you're still getting better. You're still decreasing your OR time, increasing your enucleation efficiency. So there's still no plateau. So if you get training, but you can't go to workshops, you can't get any hands-on training, webinars were just starting, and it's not really the same. You can get some tips and tricks, but it's not an actual workshop. So what I did was, and we've seen that there's a lot of cadavers and VR models available, not during COVID. So I watched a lot of videos, a lot. And that's what you could do during COVID. You could watch a lot of videos. And I watched videos from people I I think are my heroes in BPH procedures who are attainable in Europe for me. I mean, I only have to travel 2-3 hours and see them and watch them operate, which I couldn't do to COVID. But I saw a lot of their procedures and I thought, this will teach me. But as we all know, that's not enough. Batman knows it's not enough. And we know from literature, getting mentored is the best thing to do when you start, which I didn't. Ideally, you would observe 10 cases and you perform 10 supervised cases. Start with smaller prostates that you convert into a TURP, which you're used to doing, which you're comfortable with. I've done multiple, and I was very comfortable with prostates up to 80, 90 grams. I would do 100 gram now and again. And after 2 years, in this study, they've done 20 to 40 procedures autonomously. So that's 2 years, 20, 40 cases. That's not that much. Once again, adequate mentorship, really, really important. First 5 hole-ups with a mentor alongside you in the OR. That is ideal. But this is something I was not able to do. I was able to get a mentor, like talk to the mentor, but it's impossible to get somebody in your OR during COVID. Anybody who's not supposed to be there can be there. Being mentored is probably the right way to do it, which I was not able to get it done. So how fast do you get through your learning curve? If you need about 100 cases and you have a reduced surgical load due to COVID, and this is the surgical load that you get. This is an interesting paper that is talking about fellowship-trained novice surgeons who just get autonomous procedures. They finish fellowship and they start doing hole-up. How many cases do they get a week, a month? Most of them get about 1 to 5 cases a month. You need 100 cases, and you have 1 or 2 cases a month. It's going to take you 100 months. So that's a crazy long learning curve. Like we said, they tell you how many cases, they don't tell you how long it's going to take you. Luckily, this is only in the beginning that you only get 1 to 5 cases a month. Right now it's about more like 10 cases a month, which is a lot better. So it takes you a lot of time to get through the learning curve. And learning curves are frustrating. Let's agree to that. Learning curves are frustrating. Another thing I needed to learn is that all prostates can be hole-upped, also small prostates. And in the beginning, I was a little reluctant to do a hole-up for a 60-gram prostate because I thought, I mean, I can do a TURP in an hour and a half or less, and the patient's, he's okay. Catheter's going to come out the day after, maybe 2 days later, but still, doing a TURP for a 60-gram prostate for me was still fine. So my very first hole-up was a 110-gram prostate. Bad idea. Don't do that. So we've listened to your talk. It's great. Take his advice. Don't take mine. Don't do a prostate of 110, 120 grams for your first case. It's not a good idea. If you're not mentored, you don't have anybody there. Just start with 60 to 80 grams, 40 to 80 grams. It works very, very nicely. But I persisted with TUR or bipolar enucleation for too long, which caused my learning curve to be a lot longer than I wanted it to be. I was frustrated for too often. And like a lot of people in their learning curve, at some point I thought, what am I doing? Why am I doing this? But luckily I persisted. I was in the 2/3 of people who persisted. So as take-home messages, think ahead when you consider taking up a new procedure, a new technology, new pathology, and get your equipment and try and plan ahead to do that so it's all aligned in time. A global pandemic is a bad time to develop a new skill. Just don't do it. Absence of hands-on training opportunities made me move towards online content, which is not the same at all, but it's the best I could get. So watch a lot of videos. There's thousands of videos out there. So do get online content. Lack of a mentor or proctor slows down learning curve a lot. Grab every other opportunity to learn. So don't only do the prostates that you're not comfortable with doing with TURP, but do every prostate that you can. And don't fear the learning curve. The learning curve is real. You'll get frustrated, but persist and push on through the learning curve. Thank you. And sorry for my blunt honesty.
Y perdón por mi brutal honestidad.
Muchas gracias. Excelente presentación.
Thanks for such an excellent presentation. Any question?
Yo tengo una, Tomás.
I have one,
Sobre
Thomas,
el aprendizaje con
about
hands-on. Hacemos
the learning. We perform courses in Europe. Do you have those courses in Europe, and how you ensure that this course will be ethical but also safe on patients and for those who are learning?
It's a very good question. So how do you make sure that these courses are ethical and safe? We now offer BPH courses. I offer a BPH course in my center with one of the key opinion leaders in BPH in my country, and we offer the biogel models, that the Johns Hopkins model from Ahmed Ghazi. It's a really great model. So we offer that. We offer training on models, which is, I think, the way to go before you go on to a patient. And what we do also is live courses. We have small group courses, 4 to 5 surgeons that join you in the OR. We have talks in between courses, in between surgeries. And I think that's a real good way to learn. If you can have a direct contact with a key opinion leader, you get to ask questions. You do a few cases first, mentored, and then you go back to a course and you say, okay, how do you do this? I've been doing 5 to 10 cases and I struggle with this or that step. Teach me, show me how you do it. So the small group courses, I think, are a really good thing to do. I would advise everybody to do it once and again. Even in the middle of your learning curve, if you think, I've done 30 or 40 or 50, I think I'm getting there, do one more course. Go and listen and see how other people do it, and ask key opinion leaders' opinions and advice during live surgery.
Hola. Excelente presentación, Tomás. Una consulta en la selección de los
Excellent
pacientes
presentation question. When selecting initial patients,
fijarse si es un paciente usuario del
checking
software
whether it is a catheter user or who has had prostatitis, because in my case, when I was thinking that I was mastering the technique, I had patients with a probe, a difficult prostate, difficult to find the plane. Any recommendation not to get frustrated?
Persist. Yeah, that's the difficulty, especially with those difficult prostates. Push on through, bite through the frustration. Everybody gets frustrated in the learning curve of HOLEP. I did. I remember canceling a case or two because, for instance, one of the cases was a very large prostate, and I thought, okay, this should be feasible because I'd done prostate like that before, but this was a very obese patient, and I couldn't get my scope into the bladder. So I thought, I had never encountered this before, and I thought, okay, this is too difficult for me. I'm not going to do it. So we woke the patient up. I didn't start the enucleation, and it was a 160-gram prostate, and I wasn't feeling comfortable doing a TRP on that patient. Patient went on to have a robotic simple prostatectomy. What you also can do is a staged HOLEP. So do one side and come back another day to do the other side. I understand that in a private situation it may not be ideal, but whatever is safest for the patient, because having the patient in stirrups for 5 hours is not safe either. You have compression syndrome, you have VTE risk. So whatever is safest for the patient, regardless if you have to come back another day, I think is most important as well. And if you're frustrated, but you're still being safe for the patient and you're doing a good job for the patient, that's your problem, and we bite through our own problems, I think.
Okay, una consulta. ¿Qué hay? Porque yo estoy en
Another
esta situación.
question.
Hago normalmente cirugía RTU, ¿no es cierto?
I normally RT1, and my hospital is about to buy laser soon. I have some questions. There's Esteban, who is my mentor.
Pero bueno, ahora se enteró. Quiero saber.
I would like to know, and this is one of the concerns I have, about incontinence left after by the HOLEP. You haven't talked about it, and whenever I talk to someone, a mentor, they say, well, relax. Incontinence does exist, but in my mind, if I operate on a patient with benign prostatic hyperplasia, incontinence is inconceivable. So what can you tell us about that?
That's a very good point, because we want to make our patients better, not worse. And when the patient has BPH, may have some urinary incontinence, a drop here or there. But if you do a HOLEP and a patient is completely incontinent after, you didn't make the patient better. And I agree to that. And you will see incontinence in your learning curve. If you look at the literature, the incontinence within the first 3 months after HOLEP is up to 40%. It's super high. Who does HOLEP in the audience? All right. Who's had a patient with incontinence? Everybody has had one. You will have a patient that is incontinent after HOLEP. Everybody has a patient that's incontinent after HOLEP. And learning curves do exist, but I do think we need to go through learning curves partly on models, ideally, and we need to follow courses, but stress urinary incontinence or urgency urinary incontinence, you will get that. Somewhere between 15 and 40% of your first 100 patients will have that in the first 3 months, but after 1 year, it's a lot better. It's so much better. And it'll be just a few percent. You stretch the sphincter quite a bit. So it's not uncommon to have incontinence. Counseling your patients is super important. I tell all my patients, you will not like me the first few weeks after your procedure. You'll curse, you'll think, what have I done? But I promise you, well, I don't make promises, but I'll tell you that most of my patients, 98% of my patients, are really, really happy after this procedure. And the risk of having persistent incontinence after such a procedure, after 6 to 12 months, is really, really low. It won't be zero, but it'll be really, really low. Counseling your patients is important.
Bueno, al final, la última charla justamente es acerca
Last
de
talk
incontinencia, cómo
about
prevenir
incontinence, how to prevent it and treat it. So I invite you to stay because we'll talk specifically about that. Now I'd like to invite Alfredo Sanchez, urologist at the Mount Sinai and Rio Hospital, how to choose my tools, moderators Gabriel Baruso, and Georgina Gentili from the Spanish Hospital.
Hola, buenos días con todos. Qué gusto estar este año.
Hello, good morning. Thanks for inviting me again. Thanks to Pablo, Luis, the team at the German hospital for a wonderful course. I have to talk about how to choose instruments. I'm very happy for including the topic of learning curves today. It is very important, and we will touch upon this topic because we'll talk about the HOLEP and enucleation. And if it is a procedure that it's been in place for 38 years now with monopolar surgery, but he had no laser or morcellator. That's why the Peter Gilling made it more famous. If you Google, you will see plenty of information today on this kind of intervention with laser endoscopic intervention. And each author defends the position depending on his or her experience. Some say long-lived holmium, others say that thulium laser is best. Also, Dimitri says that thulium fiber is best. And lastly, Thomas says, in addition to laser, there's yet another source of energy to perform enucleation. In this case, bipolar energy, as noted, may also be an option. So we do not only have laser, we have gone back, to 38 years ago, where we see that we can use other sources of energy. Offer is vast. There are lots of lasers available globally because so is demand. When I started, just like Thomas during the pandemic, there was little supply. There were few surgeons who were performing this, and in these 4 years, things have changed a lot. I'd like to talk about the learning curve. This is a very good study from the Dimitri group comparing 3 different techniques. In the case, thulium fiber, holmium laser, and enucleation with a monopolar laser. And we see the results with holmium we have an efficient rate of more than 1 gram per minute. So probably it's the best tool. With thulium fiber, it's a little bit less, and with monopolar, far less, indeed. Now, generally, we look at the study, we don't know how they were performed, and we go directly to the conclusions. So how did they do it? They took prostrates less than 80 cc in volume. They divided them into 3 groups of 30 patients with 3 different surgeons. None had experience in enucleation before this, but plenty of experience in resection using monopolar or bipolar. And what did they conclude? That with 30 surgeries, it was safe and efficient for the person who was starting, but together with the mentor, what has been said already, but in prostrates less than 80 cubic centimeters. So what happens when we have larger prostates? Probably we will need vaster expertise, a longer learning curve to resolve the situation in these patients. And as I said, none of these surgeons had prior experience in enucleation. Let's now talk about the instruments in the context of this talk. We have dilators for urethra. There's no point in performing a good enucleation if we're going to damage the urethra. So we have to calibrate the patient at the uh, clinic. There's these calibrators. Tiago is familiar with him. I did not know about this dilator and calibrator, and I could see how it works now, and I have taken pictures to bring it to you. I generally use the conical one, and we calibrate the patient's urethra in the operating room. I don't know if you have any problems in the practice with urethral strictures. These patients have to be adequately managed. I cannot have good calibration. With 3 days is enough. When you are going to perform the surgery, you will access very comfortably with whatever equipment you have, and you will be able to have a good performance in terms of enucleation. Take-home messages protecting the urethra. Also, I'm often asked what type of fiber I use. I have always used this one, never a smaller or larger one. I don't know about you. I don't know if you have used it, but I've used these. But before that, I have to know how the fiber works. And yesterday, when touching upon lithiasis, there was reference about how laser works and how energy works, how energy is amplified to reach out to the fiber. We see the difference between a low power and high power laser. So it will be very difficult for you to achieve proper enucleation with low power laser. I would not recommend it. We see that thulium fiber offers a different form of amplifying energy, which is completely different. It's diode, it's not xenon like in holmium, and it does so in a completely different fashion. So before choosing a product, before making a decision, you have to be familiar with how they work. It is very difficult to go to a car dealer to buy a car unless you know how it works. So, and if it is a high-end car, maybe you are underusing it. So it is important to know how this works in each component. And it is also important to know how that component goes through the devices. I love it because it avoids liquid leak when you're performing enucleation, which is something tedious. Simple things may help us a lot to have a better performance in the operating room. I have enucleated with this endo camera that you see at the center. We have the one on the right, but there's also some backup. Fortunately, in HOLEB, we are largely dependent on technology and the people around us. So get used to having 2 lenses, 2 work items. The bipolar, as Tiago said, as Nicolas said, is important to have backup, some backup of all the instruments that you're going to use, because we don't know when we'll have to use them. I am always asked what the parameters are I have listed them here so that you may copy them. I have noted them here because noted the pedal on the left, you use a pulse modulator, which is the virtual basket, and this does not allow us to play around with the wave width, the laser wave width. You cannot use a long or short pulse because it's a presetting that you have. It's preset in the right pedal, you can. This is a big difference, but since sometimes we ignore, we don't know this, what the technician uh, provides is what we use. So it is important to know, even though, I mean, if I can choose the wavelength on the one hand and in the other one, I cannot. So take this into account and know when to use the short pulse and the long one. And I use Illuminis from another company. Here, yes, we can use both on the right and left. The wavelength can be chosen, but when we click on the effect button, the MOSIS technology is a different thing. Here we will block the possibility and we won't be able to use the wavelength we wanted. So this is something that you have to take into account, and you must be familiar with when it comes to setting up your equipment, and not just look at what other people are doing or experts are doing and replicating. There's no point. I mean, parameters are of no use if you cannot interact between the fiber and the patient's tissue. This is very important. We are using Magneto for a month and a half now, and see here in none of the pedals, if you use pulse modulation, it allows us to play around with wavelengths. This is very important to take into account when it comes to using this kind of device. Now then, what is there in terms of irrigation and light sources in Ecuador? In Ecuador, we have no access to 3-liter saline pouches, just 1 liter, and we have adapted a parenteral nutrition bag, which is fed with 3 liters of saline solution, and we add another, we're going to have 4 liters simultaneously irrigating the patient, and with that have a better vision. I'm always asked at what height I place irrigation, how much you use. Well, there it is. You may get adapted. I went to Colombia. They have this system, which is Neptune Striker. It is a system that allows us have high irrigation because it is electrical. It goes up and down. It has a suction system. It has been the case that the bucket gets filled and we end up with water up to our necks and we have to use boots. It's easy because you approach that cart, you bring it from the waste area, and you just change the canister that is collecting liquid suction that you're using. It is important to have an organized operating room, even though it can be overwhelming to have so many things. But if you are organized, if you standardize the procedure, if you train the people around you, you will have anesthesiologist as relaxed as the one there watching his cell phone. That means the anesthesiologist trusts you, that the surgery is safe. So you must always try to standardize the procedure and train your staff. We may speak of morcellation or morcellators all morning. That's not the purpose. Just like there is a large amount of laser options on the market, there are also different morcellators, which was not the case 38 years ago. But what about knives? What about canisters? I think it's all been the case with all of us. The canister fills up very quickly and it's tedious because the vision goes down. You have to train the person, especially in sophisticated equipment items like Piranha. And see, there's the possibility of having a 5-liter one. Generally, there's a smaller capacity one. These are minor details, perhaps, that may appear negligible, but believe me, it will change your day-to-day practice when you perform enucleation. For this, we need to be familiar. Not let's just do it because it's in fashion or the latest trend. Let's do it because we are convinced and passionate about this technique. Also, in terms of the knives, they are larger, smaller diameters, there's oscillating morcellators, reciprocating morcellators. All these you have to be familiar with. And in order to buy morcellator, you have some handpieces that are heavier than others and will be quite cumbersome when you are morcellating for your arm. There are some that are safer than others. So no matter the brand, no matter, I mean, the cost, of course, is important, but what matters is that you get to know how these devices work so that you can make a right purchase decision. And with that, perform a safe morcellation. To me, safe morcellation starts here when we decide on the neck. If we are too aggressive at the neck, there will be significant bleeding and we won't be able to see properly. We have to stay quiet during morcellation. If we move the hemostasia and the time invested in hemostasia, and if we are moving around or following the adenoma morcellation, we will cause bleeding. What is it cause Chinese morcellation? I don't know if those who have used it have realized that you have to revert the knife 180 degrees in order to use it and to ensure the knives will be facing upwards. That's because it's been designed by them. One is Chinese, and that's how it comes from the manufacturer. They morcellate with the knives down. Why? Because sometimes it is necessary. We can do it when the tissue is too hard, and this is an option. So all this we have to be familiar with when we use the equipment. And then what probe are we going to use?
Esta sonda de aquí parecería ser muy bonita, muy útil.
This catheter seems to be very nice, very beautiful, but be careful with irrigation. When we insufflate the balloon a lot, the solution will pass more difficultly and there will be a poor irrigation because we are using lateral, not concentric motion. What is important is that you should know how the balloon is inflated and be careful when you are performing a case and you see the subtrigon or retrotrigon is very invaded. The catheter can remain in that area and that can be mortal for the patient. You will inflate the balloon there, you will dissect the area, and all the fluid that is coming in will move towards that place and you won't explain, you won't understand why the patient did poorly. So be careful when you use this type of catheter, especially when the tip is directed in a different direction. So what type of catheter to use? Well, we use a normal 120 French 3-way, but as you'll see at the end of the video, maybe we can fast forward it because what I want to show you is how we place the catheter. If you can, it's okay.
La colocamos hacia arriba. Sí, la pegamos
we
sobre el
place it
abdomen.
upwards. We place it in the patient's abdomen. We inflate with 40 cubic centimeters, regardless of the size of the prostate. I think that prevents the migration of the balloon towards the lodge, the prostatic fossa. The catheter has to remain in the bladder, not in the lodge. Some do it like that, but I admire them because to me that is not the right thing. I think that the fluidity of the irrigation decreases and it's not the right thing. In my experience, what we have to do is to fixate the catheter towards the patient's navel. We fix it like that. It doesn't move to the lodge, and the pelvic limbs are free. They can walk the next day. They can move without being afraid that the catheter will move. Now, what about the lower diameter equipment? Are they good? Well, this is the smallest we have used. Internally, it's 17.5, outside 18.5, the diameter. If you are going to protect the mucosa of the urethra, of the sphincter as such, at the level of the membranous urethra, that will sacrifice vision. You will have a poorer vision when you release the apex because the irrigation will be less and you won't see towards the bottom when you are morcellizing because these equipments have a 9 millimeter lens, so there is less light passing through. This is another example of instruments with a reduced diameter to see how the mucosa is preserved, and if there is such a big supply, what do we use? We use this at 24 French equipment, 30 degrees with a 0-degree morcelloscope. We don't use Kunst element. I don't like it. I like to feel the fiber and get closer or farther away from the sphincter or the sphincter mucosa. I don't like to be using that element as such because I feel that you lose sensitivity and you cannot be accurate. The clarachroma effect is important to use because it helps you differentiate better the plane. It helps you to better differentiate the tissue, and that is something that could help. And this video here in the middle, this had already been discussed. I don't know whether we can play that video.
Bueno, es un video que hace
Well, it's a video that shows that it's important for you to record your procedure so that you can share it, and also so that you can watch them later on, and so you can see what you're doing wrong and you can correct it in the following procedures. Maybe we can put up the presentation.
Ok. Vamos a pasar al siguiente. Bien. Este es otro ejemplo
This is another example of what we are doing now. We had the opportunity to use it for the first time in Mexico at the Congress 2 weeks ago. You will have an excellent hemostasis with this equipment. This is one of the main differences I could note with the use of magneto. It's a combined equipment, holmium and thulium. You will have an excellent dissection, and you will be able to have a better plane when you are performing the enucleation. Here I brought a surgery that we performed with this equipment of an intermediate size adenoma, 100 cubic centimeters. And what is important to notice is the quality of the dissection of the plane and the major hemostasis that this equipment contributes, which makes it different from a 100-watt equipment that doesn't have pulse modulation. I think that's one of the main advantages. If you have one of these equipments, you could think about the making an upgrade to this one. There is a difference, even if we may think it's not. And when you use it, you will note the quality of the plane dissection, the quality of the hemostasia is very good with this equipment. So it's something that you should bear in mind. Once you have already finished with the enucleation, place the catheter, discharge the patient, remove the catheter. This can happen. The radiologist doesn't know how to measure, and the patient will complain to you, and they said, you operated on me 2 weeks ago, and my prostate is still there, but it's poorly measured. So you have to talk to the radiologist and explain to him that this is a new procedure. It's also new for them. And you must have good communication with them in order for you to tell the patient that it was an involuntary mistake by the radiologist and that the prostate is no longer there, but it's not correctly measured. Now, with respect to the beach balls, you can use several things to remove them: baskets, forceps. We have the option of gastroenterologists, some that are not aggressive. We use the dormia. until we had an accident in some other country. If you see the image on the right side, it looks like a small adenoma, 1 centimeter, but look what happened when we removed it. It broke the urethra. We were in the fifth case. It was a large prostate with nodules, filled with nodules, those that when you think, should I come back? Should I just leave it? And we try to remove it with a Perkin circle basket, that the ones you use for percutaneous, and it tore the urethra. Just like Norberto said yesterday, that you should have friends in a situation like this, radiologist, an interventionist radiologist or cardiologist, you should have their telephone. And here in this case you have to have a friend that treats incontinence. Fortunately, we had something that had received training with Pulcardi, and he resolved it well, and the patient did quite well. But don't despair. I learned that I should not despair when I perform the surgery, and it's better to leave it there and leave a catheter in, and 1 week later finish the morcellation. So by way of summary, I hope this has taught us how to use the instruments that you will use on a daily basis, and this is how your colleagues in the OR will see you. So you have to choose your instruments well so that you can offer safe procedures to your patient and not just be led by what the industry says or by the leaders in the media, but you should know how the instruments work so that you can make a good decision when you purchase them. Thank you. Well, thanks for your presentation. As Dr. Castillo commented, there are different realities regarding technologies and instruments. For those who want to start with this surgical technique, what do you recommend about the type of laser and morcellation? I mean, regarding the investment, the urologist or the team that wants to invest, how should you start, or is it better to start with a bipolar technique and then switch to another? Now, I don't think it's necessary to start with a bipolar technique. I have never done it. I respect it, but I don't think that migration is necessary. I think you can do surgery with a nucleation laser without going through that process. I started with 40 or 60 watt, but it only gave 20. It was the cheapest then, about 5 years ago. You hadn't all this supply of lasers, and from a financial perspective, we started with that. It helped me not to have a serious accident because it didn't have the strength, or the energy wasn't the one that could harm the capsule. I think that was something positive of that laser, but it was very slow. It got heated very fast, so it actually becomes a headache. So I do not recommend to start with low energy. 100 or 60 to 100 is the right laser, not necessarily one of 150 high power. If you have one of 60 or 100, you can start with a nucleation safely, not necessarily with one of 150. Actually, you don't use 150, you use 100, but remember that 100 watt laser doesn't deliver 100, it delivers 80. So those are the things that you have to bear in mind when you are purchasing an equipment. Thank you.
Voy a preguntar si alguien tiene una pregunta.
Do you think that the investment has to be major? Because you said that to start, you have to have the elements. Well, clearly that's the thing, but you have also to duplicate everything, a double optic, a double resector. So what's your opinion? Because you can have a double optic, etc. But what's the point when you need to have two lasers? How do you approach that? How do you solve that? Do you have a backup? Do you use another equipment? Because in some places they hire the service and they have the laser they want, but when you have to pay for it, well, having two of each is difficult. But you saw how we started and how we are doing it now. It's a process. I saw centers, I went to Europe, and they have a laser backup, and it helps because we will rely a lot on the technology in this type of surgery, and the laser can get damaged during the enucleation. It's important to have another equipment. In Latin America, that is more difficult. We don't have two lasers. We have two, but one is for lithiasis and the other is for HOLEP. It's very complex to have it like that in an institution. I don't think it's an easy option in our area. But if you can have it, well, that's the ideal thing, because the laser can fail at some point in time, and it's not so easy for us in Latin America to have two. We can also buy used second-hand equipment. But do you think that there is an age, a cutoff point for the age in which you will start this? No, we have trained very young urologists in the hospital. We are 5. There's someone who's 34 and has learned with us, and someone who is 60 and he's enucleating alone. So it's a matter of passion, not of age. You have to be passionate about this so that you get involved and you get into this whole lab world, and you start to see to watch videos every day, and you invest in medical education, you visit experts. So it's a matter of passion and of willingness rather than age. Last question. We are starting, and one of the greatest complications we have is instruments. The only thing we are missing is the element, and that because I have to be concerned about the fiber, put it in, put it out, and you didn't use the element. Was it, or has it always been like that, or is it now? No, I used it at the beginning, but it's very cumbersome because when you turn and you go in and out, and the Kunst element has a catheter fixator, it's not only the stabilizer, it has a button, and the fiber gets fixed, and that is cumbersome. I like to move it forward and getting away from the tissue. So that was a limitation, and it is also heavier. We have weighed them, and the one with the Kunst element is heavier. And if you have to do 4 or 5 procedures a day, well, probably your extensors will suffer. So it has been a matter of adjusting. A Kunst element I use when I go to other places, and it's not a limitation. I've learned to use it in both ways, but my choice and what I do on a daily basis is what I showed you. It's the element that has the fiber guide, and I can move forward and backward. It's lighter, and it doesn't justify having your finger in the Kunst element because it doesn't provide more accuracy or more precision. It has been designed like that, but you can skip that. Thank you.
Bueno, continuamos e invito al doctor Said bin Hamri.
Now, Dr. Said bin Hamri to speak about laser and configurations for enucleation. Moderators, José Antonio Salvador, and Tiago Jota.
This is a very rich session about the enucleation. I am glad to present the laser setting and the cost analysis because many of you ask holmium, thallium YAG pulse, or TFL. These are my declarations. So first of all, you need to know that the color has nothing to do with the technology. Green light, red light, holmium is this one is laser, that one is a green light. And you have to know that the color has nothing to do with the power. This one is a stores luminous, this stores laser. So it's a different company, but the same laser. Let's go for the test talk about laser PPH. Everybody is asking, what is the best setting? Because learning curve is difficult. I will just expose you to the take-home messages, which laser you take, because a while ago when someone asked which laser I start with to start my inoculation. Holmium laser. You know that story. Peter Gilling in 1996, one of the famous studies. You start doing the inoculation almost, and the same. But the question here, you need an 80 watt to 100 watt, like Alfredo said, that you need a high power machine to make these decisions and aspects. And you have to know that if you come to the apex, you need to work in a low power mode, that it helps you to avoid any dissemination of the energy toward the sphincter. So you have the options to range in the holmium, in the anterior face, release, middle loop. Now, the holmium, the cost effective, it's been shown in European that it's very important because the cost effective, there is a direct cost and indirect cost. So the TURB was very cheap toward the open surgery, but the HOLIP showed that is very safe to cost for money because the less of hospitalization. United States, they care about the hospitalization. That's why you raise more money. Let's go for the TFL. The TFL, same principle. Look at this, holmium TFL. We did a landmark by the TFL and the early release of this apex by the holmium. It's the same energy, inoculation is inoculation, but you have to know what is specific for TFL comparing to holmium, because holmium is for the experts in the urology, or the expert in the HOLIP, but the TFL is for the beginner. So what are the advantages of, in fact, such laser? The advantages, if you ask me, the charring has nothing to do with the hemostasis. It's because you touch the tissues much, and you can see that charring. So if you don't want any charring, do not touch the tissue. You try to inoculate mechanically, and this is the other disadvantage of the TFL, which is you need mechanical force rather than the holmium, which gives you more bubbles and ease your life. Again, this is a middle lobe, TFL, comparing to holmium. You can see the same effects. It's the same effect, and maybe with the hemostatic effect with the TFL is much better. Of course, hemostasis efficiency is much better with the TFL. It helps you to not scared and not be frustrated. TFL is very powerful for hemostasis. You can see here, this is a little bit of mechanical, but inoculation. Then again, another video shows you how efficient the TFL in the controlling the bleeding. And the setting between 1.2, 1.5, 30 hertz to 25 hertz. The anterior face release, it's true that HOLIP might be very nice. It's true with the charring, the bubbles, but look at the TFL, because it does the good job. It's like if you lost, you can cut. And this is the advantage of the TFL rather than the HOLIP. And you can see here exactly, this is, if you lost, you cut. And this makes your life easy because with the TFL, if you're losing the plan and you want to go for learning curve, you cut and finish the operation instead of wasting time by shifting to the bipolar. I'm one of the guys who started the learning curve with the TFL, then I shifted to holmium. But TFL did a great job with a great result. These are pictures of complete inoculation of about, I think, 60 grams. The TFL 1.5, 30 hertz. Another picture shows you that this is a small, medium-sized prostate. You can see clearly the efficiency of the hemostasis and the clarity of the vision you need with the TFL. By the way, in the short pulse, you do the inoculation. By the long pulse, you do the hemostasis. The long pulse is for hemostasis in the TFL. Many studies, randomized prospective studies, showed both surgeries in terms of duration and postoperative complication, HOLIP and THULIP. The long-term results in 1,300 patients, effective and durable. What beats the other monopolar or the bipolar is the learning curve. The laser, the HOLIP-THULIP, appears to lend itself quicker adaptation comparing to the other procedure. This is a very funny study. It's not something might be indicative for the guys of the TFL, that the erectile dysfunction must be better with the TFL. As you can see here, the results. This is not, I'm not biased for TFL, but I found it in the literature, so it seems to be funny. So again, it's not about the hemostasis, because what does the hemostasis is the technology. The peak power is for the stone. It's not for the prostate. But however, if you want a mechanical dissection, you go for big bubbles, 2,000, 10,000 with the holmium. That's why when it comes with Magneto, it did not come for the dissection of the prostate, it came for the stone, it came for the stone itself. But it gives you wide area of the range to treat the stone and the PPH. It's not for the PPH and the hemostasis itself. So we have to distinguish about this. I have no experience with the Tholio, the pulse, but it's appear that is very efficient for the prostate. I might have it in a month. So what gives you an idea about the HOLIP is shockwave mechanical dissection effects, which is very nice for the pioneers and experts in HOLIP. So the take-home message here that HOLIP is a better, yes, it's a peak power because we need a high peak power sometimes for to make the plane and dissection, it's important. Unlike the stone, you need a low power peak, yes. TFL is for learning curve and the cost. If you want to start your HOLIP or THULIP, go for TFL. It's less cost and more learning curve. Modified HOLIP is yet to be discovered. Magneto just came to the market for 6 months. We cannot judge it unless we have our time researchers and the key opinion leaders. Thank you.
¿Preguntas de la audiencia?
Any questions from the audience?
¿Tú tienes alguna preferencia por
The mic is too low. Do you have any preference when it comes to choosing one or other laser? I mean, choosing holmium over thulium fiber. Does size have an influence?
Holmium and TFL. Okay, for the TFL, I have two choices, patient to an anticoagulation. And for the holmium, the first choice is the size of the prostate. If the size of prostate above 100, 120, holmium is much better for the dissection of the plane. But if you have a patient with anticoagulation, we go for the TFL. If I have my resident, I let him start with the TFL because it's much easier for him. But if I do my work, I will use a high power machine, a holmium, especially for big size.
Sí, ¿crees que
do you think that using TFL by using mechanical energy for dissecting the adenoma, does that impact patients' incontinence?
The people, they do the inoculation with bipolar, so there is no changes between TFL and bipolar. So the point to avoid incontinence, this is the big opinion of the endourologists, that is the early release of the apex. So once you release it, you don't have to worry about the mechanical inoculation, even with the TFL.
¿Más preguntas de la audiencia, Tiago?
Any other questions?
Buena presentación.
Very good presentation. How do you setting when you are using thulium fiber? Do you try to increase power in order to have more pulse energy, or do you try to improve the frequency to gain more speed?
The problem with the TFL, there is no increase of speed. You can have it increase in speed of the holmium because you have a range between 2,000 to 10,000. So you can have the bubbles as big as big, but the TFL is limited with 500. So TFL is not good to find the plane. It's good for ensuring that the hemostasis is there, you can cut it with it. But to have that range of a speed is for the holmium, it's not for the TFL. TFL is stable, it's 500. I cannot, it's a small car, safe car with a seat belt. Holmium, it might be a big car for juniors and you can put dissection. You have to know the plane in the holmium and you can swim away. TFL gives you the safety as you drive, but it's limited by 500. Whether you put 4 joule, 3 joule, it will be the same effect, except the charring with high energy.
Estamos entonces. Muchas gracias, Said.
Gracias.
Buen día. Empezamos agradeciendo el primer
Good morning.
día.
We started by thanking on day one, and we continue thanking Macarena. Thanks very much for the pictures. Wonderful. Paolo, the light team, and the open media who has done this wonderful transmission. Please stand up.
Quiero invitar al doctor Javier Pizarello, que es nuestro jefe de residentes. Han habido más de 100 conferencias.
There have been over 100 conferences, and Javier has organized them all. So, Javier, please present your resident team who has done the behind-the-scenes work. Please come on stage.
Hola, buen día, ¿cómo andan? Bueno, acá los chicos han trabajado un montón en este congreso, en cosas capaz que no se ven y cosas que sí salen.
There are many people who have worked in this Congress, the videos, talks, presentations, coordinating the modules. I'm going to start with Julieta.
Bueno, Guillermina Figueiras,
third-year resident, Pablo Sáenz, fourth-year resident, Victoria Zorita, fourth-year resident. She's the one who talked to you and coordinated accommodation, hotels, transfers. Our endourology fellow who worked with the schedule, Esteban Ochoa, and Carolina too. We have an intruder, Facundo Martin. Please come on stage. So I hope you have enjoyed it. They have worked a lot, and they're an important part of this project.
Felicitaciones y muchas gracias a todos. Vamos al café.
Congratulations. Let's break for coffee. available in our Instagram profile. You will be able to take all pictures from there, but the top influencer measurement will be done in Twitter. So we post them with that hashtag, and the winner will be attending the Congress for Free in 2025. At the end of the course, we will have a walking tour around Buenos Aires to relax a bit. So you are all kindly invited. It's a wonderful day out there. We have a unique opportunity today. Thomas yesterday talked about training curves and told us that you had to operate on 50 cases to feel comfortable. With 100, you felt even more comfortable. But today we have a unique opportunity. Nicolas told you you must have a mentor nearby, and these are proctors. They are mentors as well, and they are teaching surgery throughout the world for many years now. And they do not have 100, 500, or 1,000, but thousands of cases that they have participated in. So what they can teach us is most enriching, and they have a huge speaking abilities, and they're very generous to convey their knowledge. So it's a great honor for me to moderate this 10K, almost 20K panel if you add up all of their cases. So Hugo de la Rosa Barrera, Tiago J, Holger Rurilis, and Mariano Gonzalez, please come on stage. Thanks.
Estas son las compañías que nos acompañan en
These
esta
are the
sesión.
companies accompanying us in this session. It's interesting. You will be able to see 4 different devices. They will tell us about their features.
Pero vamos a dejar que hablen los expertos. ¿Podemos comenzar con los videos, por favor?
Let's start with the videos.
Esta es una oportunidad que no es sencilla.
This is not common to see 4 proctors telling us about their step-by-step surgeries, 4 surgeries simultaneously with different devices, and we are going to ask each of them to tell us about their new devices. Mariano, what are you using? Well, this is a pulsated thulium. It's a different concept vis-a-vis continuous thulium and thulium fiber. When we look at this video, the reality is that we came into contact with this only recently, and our experience has historically been using holmium. With this one, remember that we find a peak power with 3,700 watts, as a result of which it's quite similar to what we may find when we set the laser holmium equipment at a modulated pulse. This allows us for hemostasis that is quite good in a first step, and at the same time appearance of the plane. When you use thulium fiber, we sometimes have the difficulty that the bubble, as we know, is not sufficient to dissect tissue. Here we find exactly that. The ability of having good plane dissection added up to good hemostasis. Holger, what are you using? I'm using Jena laser, 150 watts. I've been using it for some 4 years now after using Austin. And the big advantage I see is first, high energy or high power and integrated morcellation. Thanks, Tiago. What are you using? I'm using Cyberhold Quanta, 100 watts, with no possibility of using magneto, and pulse modulation, as Mariano said, which lowers peak power compared to short pulse, but gains a lot in terms of hemostasis. The advantage is that you can modulate pulse, so you can make it shorter to have a peak power of 10,000, but also 3,000, 4,000 with pulse modulation, as it is the case with thulium with a peak power of 2,000. I like using it. Hugo, what are you using? This surgery was performed using Lumenis laser, 120 MOSIS technology. MOSIS technology is modulated pulse offered by the company. We have always to differentiate it from the MOSIS effect that all holmium lasers cause. what they call the MOSIS technology is a modulated pulse, where what we achieve is delivering more efficiently, delivering energy more efficiently, because we know that energy in holmium gets scattered before reaching the tissue. Here, 60% of the energy is delivered to the tissue so that we have better coagulation capacity, better first step coagulation. As we perform the dissection, we may coagulate. And what I like about this equipment is that you can turn on and off the MOSIS. Whenever you need a more expansive bubble, you can switch off the MOSIS, shorter the pulse width, and have a better dissection. This is a versatile equipment that allows you to modulate and manipulate what you need, in that case in point. Can we restart videos, please? Is that the beginning? Okay, Hugo, tell us your step one. We see the sphincter. What are you doing? Well, what we are doing here is assessing a physical assessment of the sphincter. We cut irrigation to anatomically define where the sphincter is. Irrespective of that, we perform an assessment of anatomical structures, such as verumontanum position, middle lobe anatomy, presence and distance of meatus, and we always start with an apical dissection, an incision in the J or hockey stick shape in the rim between lateral, the left lateral lobe and the verumontanum. This is the site closest to the surgical capsule, and we start using the fiber at time 5, and as the laser opens the dissection plane, we rotate the fiber. In the second step, we go above the verumontanum, and we extend the incision to the other side in order to complete the incision in omega. And then we will progressively open the mucous bridge. Unlike the initial mark that Mariana will talk about, I like opening it progressively to identify the tip of the adenoma and dissect it completely. Let's restart the videos, please. Tiago, what are your initial steps? I find the plane near the verumontana because we have to interpret it. So it is easier to find it near the verumontanum. Once I find it, then I just connect the cristoreteral. If you go below, you open the ablator. So that is why I perform many surgeries, and I want to have the certainty of the posterior plane, and it will go along the posterior plane when you start performing the release. Always we do it progressively, trying to connect to the posterior one, which is the safety plane. Holger, tell us about your step one. Not very different from what we have heard. What I can say is I come from having operated many cases with a conventional technique, and it's only 4 years or 3 years ago that I changed on block. I start as Tiago and Hugo at 5 and 7 hours approximately, opening the plane and trying to determine what the prostate is like in terms of tissue and bleeding. I do this and the posterior portion with a lower power, but I continue using this low energy in every stage close to the sphincter, and it's only when the sphincter is completely released that I change to higher power. Let's restart the videos one last time. Mariano, your step one. Well, this is completely different from what I started. When I started 19 years ago, I would use the Peter Gilling complete cut at time 5, then time 7. We would raise the middle lobe, cut at R12, and would remove the lateral lobules, leaving, and we said this over and over again, leaving 1 centimeter portion between the adenoma and mucosa in the upper aspect, considering that we're seeing in the anterior aspect. Then there was the bilobe technique, which we followed for many years until we started going for the block technique. The bilobe technique is left for larger prostates, 150 to 200 cc's, cubic centimeters, with a modified bilobar technique. But here we are making early marking of the mucose using the drape technique that is going up along the adenoma. And this initial marking is not the apical release, the early apical release. This is very important. People sometimes believe and watch videos. The mic has gone off. You have completely released the sphincter, and it's not true. Oftentimes, if we have a large prostate, prostate growth will be towards the sphincter area too. So if I mark, I will have the adenoma growth that goes to the posterior side. So if you look carefully, we make this marking at the beginning with low power, but then we follow the adenoma. We look for it at the same place, times 5 or 7, next to the veromontanum, where we have a plane with far less adenoma, thus allowing us to entering the site more easily. And then we follow the adenoma to release it, not believing that by just marking it at the beginning, it's okay. That would lead us to not performing an early release, and maybe the tissue may tear. So we move towards, we start with the floor, and then we start with the side lobes. Tiago, you're caught at 12. Where do you perform it? Above the verum, because in cadaveric studies, we see that the sphincter is tilted above the verum on the anterior aspect. So that is why I do so, but it's a bit ahead in the case of more risky patients in order to maintain the muscular fibrostrom. In post-radiotherapy patients, I maintain the stoma up to the neck, and in small prostates too, thus preventing the risk of neck sclerosis. Tiago, sorry, Holger, what are we watching now? This is the left lobe. I'm going up. I have performed the release line, and I'm going up laterally with low power that is changing. And that I do simultaneously on both sides to be at the same level towards the neck. Hugo, when you find the plane, do you change your settings? No, the setting that I will start the surgery with is 1.5 joules with 35, 40 hertz. I will change the setting depending on the adenoma's response. If it's highly fibrous, that is not easily dissected at low power, I may increase my bubble to 2 to 2.5 joules to improve dissection power. In terms of frequency, this relates mostly to the speed at which I want to work. I always work between 35 and 40 because there's always trainees with us, and they will more comfortably be able to get training using that speed. Mariano, do you emphasize the fact that whenever watching a video, you have to watch the full thing, not just the endoscopy and the hands? Why? Because the enucleation technique is completely different from the resection technique. If you come from an endoscopic resection technique, enucleation is totally different. Notice the movement, the hand movement. At times it will be downwards, sometimes sideways. Positioning the patient is very important. The patient's legs, especially if I have a large prostate, because oftentimes I will end up uh, uh, colliding against the patient's leg. Why is it important to watch the whole video? What happens? Surgeons oftentimes will post the nicest videos and the nicest parts in all social media because of your ego. I mean, you need to show off. But from the concept standpoint, for teaching purposes, to conveying knowledge, this does not offer any benefit. That's my thinking. Why? Because you have to share those times where you get stuck, where you have difficulties to learn and know how to come out of the difficulty. So it's very nice to see the surgery when everything is okay, no bleeding, everything is fine, but that won't teach us anything. That shall just advertising, marketing for the one uploading the video. So I always say, watch unedited video with hand movement too, because hand movement sometimes is not interpreted until you see it live and until you sit down. When you sit down doing a surgery like this, translates into seeing it differently. When we started with this, it was a solo care with no proctor or mentor. And at times, what Thomas and Said said is very important, having a team. If you do not have a team behind you, at those points, frustration leads you to quit everything. I conducted prostatic enucleation, and they would take 3-4 hours. And I got home and said, why engaging in such a mess? The anesthesiologist told me, why not make an incision on the abdomen and that's it? Well, it took me years to learn, but what is important is to go forward. If you have a team supporting you, driving you, it will be easier to face this. Today, there's no possibility of doing all this alone, and you should not do it alone under any concept. There are proctors, mentors, major surgeons with significant expertise. That is important. Watching the whole video is just for learning purposes. I'm starting, and there are prostates that are longer or wider. Where will I find more difficulty? We talked about the prostate endoscopic anatomy. There is a study by the Turkish saying that if there is 1 more centimeter in the transverse diameter vis-a-vis the longitudinal diameter, surgery will take longer and it will be more difficult to perform too. Sometimes we are performing dissection that is very open. We try to remove the whole side, but it's not possible. So in those cases, I perform a cut to create space. But for those who are learning, who are in the learning curve, better perform a longitudinal 150 one vis-a-vis 100 cross-sectional one. There is a very important paper on MRI and enucleation, and depending on the type of neck that is of the apex, will the difficulty be. That we learned from patients who undergo MRI because of prostate cancer or for prostate cancer control. There are prostates that grow a lot contralaterally, but the most difficult ones are the ones with significant subtrigonal growth. That's the main problem. If you attack the problem directly, you will not be able, if you approach them directly, you will not get directly. And the side approach is not easy either. You talked about the start, releasing the apex. How do we do at 12 not to go pre-vesical? It is important that we follow the capsule anatomy. We follow it as per the anatomy shows up. At 12 or in the anterior aspect of the prostate, it's always safer to access the bladder because the curve is smaller. What we do and recommend people doing, those who are undergoing training, is to orient the fiber towards the adenoma so that the largest power is received by the adenoma, not the capsule, to preserve capsule integrity. We turn the fiber towards the capsule whenever we need to coagulate. But even that will open up the path and showing us the site where we will be working. Holger, where are we now in this video?
Felice propósito.
I did it on purpose. It's 11:30 of a Wednesday. We are in the same place as before. So I think, adding to the other response regarding having issues, it's an intra-op issue. What may help you a lot is standardizing everything. And that, I don't say just for the sake of it. It's like that, standardization in the OR, standardization of anesthetics, everything that happens. Standardizing all this is very important because it reduces stress levels and it creates a climate that is very important, especially for the people who are learning. By way of anecdote, when I learned in Germany, I had 15 minutes during the first 50 cases. I don't know if I told you about this. There was significant pressure. I had to perform many surgeries. So for the first 50 minutes, and I could make more and more. I went so far that se cortó el micrófono. My mic stopped.
Y bueno, eso es una forma de aprenderlo.
That is a way of learning and using it on a daily basis, and there is also much financial pressure. Is there a mechanical maneuver that you're doing then? No, normally I don't.
Micrófono. Bien.
Okay.
Mariano, nos quedan
Mariano,
2 minutos.
we have 2 minutes. You have to bear in mind several things when you plan this, and this is what we were saying at the beginning. First, that the enucleation technique with the bubble is not mechanical, and I think that's the notion you should have. You can enucleate with anything, but there are different energies to enucleate, and this will allow for different moments of the surgery to be better. You should also take time to do hemostasis during the enucleation. Oftentimes you get scared, you are wasting time. No, you are gaining in the final hemostasis, and many times the beach ball appears. And in that case, you have to have the resector ready, because not only the traction elements like a basket or a forceps will solve that. With the old morcelizers, the one we use for 12 years, and we could do enucleation in 80-90% of the cases. We had beach balls. It was the reciprocator, and nowadays with oscillating it's much less frequent, but you have to be ready, and many times you have to resect the beach ball at the end of the procedure. I think that is not something to be afraid of. And complications, well, I can share all of them with you, but I think that one should be very careful in standardizing a surgery, try to meet the different steps of the surgery to get the best results in the procedure. Holger, you get to the end of the procedure and I have to coagulate. Do you change the setting? So what do you do to have good hemostasis? Well, I always have the bipolar by me. I use it very infrequently, but I work with a setup that I work with, and I don't change it. 60 watts.
Bien. Tiago,
Tiago,
vas llegando al final.
you are getting close to the end. Do you change the setting, or do you stay it, or you manage the distance? For final hemostasis, before morcellation, I use thulium, vapor thulium, but I have my right pedal and with a longer pulse, and I load the energy because the peak power is a way of energy. Because of the length of the pulse, I lower the energy to 1 or 0.8, and I increase the frequency for 40 or 45 to give time for the tissue to lower the temperature. So, and of course, I work with the distance. That's the main point. Thank you all. Last comment, Hugo. How do we know that the hemostasis is enough to start morcellating? Well, there has to be no blood. The safety of the morcellation relies on an area without blood, because we need to see not only the adenoma but all the surrounding structures. Do you close the water? Yes, we close it. And before we used 2 irrigation systems, now we use 1, and high pressure in the bladder with closed drainage, and that is enough. Well, thanks to all of you, and it has been our pleasure to hear what you had to say.
Bueno, seguimos adelante.
Well, now we'll move on.
Vamos entonces a llamar a Hugo López Ramos, que es urólogo
Hugo
del
López
Hospital.
Ramos, who's the urologist in Hospital San Ignacio in Colombia, in Bogotá, Colombia, and moderator Rodrigo Jauneda from Córdoba.
Buenos días otra vez, muchas gracias.
Good morning and thanks again. We divide in prostates below 60 and over 100. Alfredo mentioned this has taken 20 years, and we discussed this with Tiago in Brazil and in Ecuador and in Argentina, and it has come here to stay the standard of endoscopic surgery. Here we speak of the volume in the European guide that says for higher than 80, you enucleate endoscopically, you can use open surgery and laparoscopic or robotic surgery, although robotic is very expensive for a benign pathology as this. Many times people think that enucleation can be done for prostates larger than 60 or 80, not necessarily. If you have a capsule, you have a plane between the adenoma and the capsule, you can resect it, you can enucleate it, and you have to consider different techniques that some patients won't ask us to give them the technique to preserve ejaculation. We have a number of options between 30 and 80, vaporization and other techniques, and the American guideline is a bit more extensive, but in the US two things have happened. Enucleation, although it is true that the number has increased, in the US, they get paid more for a minimal invasive technology compared with prostate. If they do the procedure in the office, like a Eurolift, for instance, it's they get more money. If I see a hammer, if I have a hammer, I see everything as if it were a nail. But you have to adjust to the needs of your patient, and patients want less invasive procedures, knowing that they can sacrifice the activity. And there was a study presented this year that said one thing is what we see in the studies with minimal invasive, and the other thing is real life. He studied with Medicare, and what happened with all the patients that were treated with minimally invasive, and the treatment rate is 15 to 20%. So if the prostate is small and they doesn't want such an invasive procedure, they have to know that the retreatment rate is 15 to 20%. So you have to explain that because they are going to see that in the office and the patients are requesting that type of technology. But clearly we have the studies, suction and miss compared to surgeries. Surgery is much less. Another important thing, what is efficient in what I do to the patient? There is a measurement of PSA. We know PSA is a measurement of the efficiency and the result. We're going to do enucleation. If it was good, PSA has to be below 1 nanogram per milliliter. And what you see here, the open surgery and enucleation lower the PSA the most. And this is what we are seeing also with the patients when we do an RTU at 1 year residual, the regrowth or residual is 41.38 at 1 year, and at 3 months, 38.79 gram. So that's why we do staged RTU. Sometimes the people have to undergo 3. So we can use the enucleation, which is a more thorough surgery. The risk is less in smaller prostates. The bleeding is much less too. For larger prostates, we have already heard it this morning, and you have to evaluate carefully the patients with small prostates. It is clear today that urodynamic doesn't show any difference because you don't need a certain specific study prior to the surgery, except if there is a neurologic condition or the patient is older than 75 or younger than 45, because I would think that there could be something else besides prostate, but maybe what we see later on is different different than what we saw first, so we should know very well the anatomy. We present this, what happened with the nucleation. This is a study by Dr. Dimitri, published in Urology, and we see that what is recommended this morning, the ideal patient is between 80 and 100. What happened with small prostates? One, the capsule is less mature and the risk of complication is higher, just like when we did transurethral surgery, there was a higher risk of perforating and bleeding and contracture of the vesical neck. And if there are nodules that affect the prostate, it will be more difficult. The recommendation is if we are in the learning curve, we shouldn't treat prostates higher than 120. We start with them once we have done 20 or 30. And when it is smaller, the risk of perforation and incontinence is much higher. It was mentioned in those patients because the sphincter, which is oblique, and I have at 12 o'clock, I have to go a bit further back, and it will not sacrifice the efficiency of the procedure, but I gain a lot in incontinence. It's very important with any energy you use, be it laser or bipolar, you should always stay in the capsular plane in order to have a complete procedure. Another fundamental thing, it has been proven that patients that were taken to BiPolep, they had higher rates of contracture. The contracture of the bladder neck has three consequences: small prostate, to the patient where the neck is hyperresected. When I see the fat, he will have a contracture of the bladder neck. And if I leave a catheter in, then there is ischemia in the neck, and then there will be a more contracture. Finally, this study that shows the comparison in the times of enucleation and results, this was published in 2020. Andrologia is the name. All the journals speaks about enucleation, different aspects, all of them related to enucleation. I recommend it. And if you have the less developed capsule, there's a difficulty to find the place, a higher risk of incontinence and post-op complications, and higher rate of perforation of the capsule. It is key in moderate prostate. The efficiency in the enucleation will be better and the bleeding will be less, but the intra-op complication is 2%. So you should know this and you should remember this. It is key when you evaluate the patient to consider the size and the morphology. When you have to have in your mind the shape of the prostate, and to plan surgery, you have to adjust the technique to the size of the prostate. And if the prostate is longer or broader, then we have to take a different approach and follow the patients up. There are different complications. Patients with smaller prostate also have more irritative syndrome because of the capsule compared to larger prostate, and they require more anticholinergic treatments and non-steroidal. So identify and verify the capsule. You have to identify adequately the apical plane, know the parameters of technology, and know how to use them in the different stages of the surgery, and the interaction of the laser with the tissue. You should know the depth of the laser, because the green is deeper and it creates more irritation symptoms because I ablate more the capsule, I char the capsule more, and the patient will have pelvic pain and dysuria for 4 or 5 months, requiring anticholinergic and anti-inflammatory. The learning curve in intermediate sized prostate, because you have to be careful with small cortex prostates. You have to be very knowledgeable about the anatomy and consider other minimally invasive technologies. Thank you.
¿Alguna pregunta?
Any question? Excellent presentation. I want to highlight this issue of the learning curve in intermediate size prostate because the small ones are a challenge. What is your opinion about reducing the diameters? Felipe Figueredo has proved that it worked quite well because besides that, the Latin American urethra is smaller than the European and the risk of stenosis is also because of the time used in the urethra, but such a small prostate is not ideal for first cases because you'll have complications. And the other relates to lowering the setting of the laser. How much do you? Well, ideally up to 1 joule and 20 because the risk of thermal lesion is much higher, and for mechanical enucleation, the risk to attract the sphincter also results in problems. In these prostates, why enucleate and not do bipolar? I was expecting that question. We cannot say that I will do enucleation. If I have a small prostate, the RTU is not bad. It is quite good for the patient. The risk of neck contracture, is it more related to the prostate volume or that there are more possibilities of perforation, a leak, and fibrosis? Yeah, precisely the second thing. The perforation is much larger. The risk of contracture when I generate fibrosis in the area, if there is urine in the neck, it will close.
Muchas gracias.
Thank you.
Bueno, Hugo ya nos dio sus
Well,
consejos para
Hugo has already advised us on small prostate. Now we are going to ask Holger to share his tips and tricks for prostates larger than 150. The panel, Valladares and De La Rosa.
Bueno, voy a comenzar con un comentario que ha
Well,
hecho
I will start with a comment made by Thomas. He ended his presentation saying, thanks for sorry for the honesty, but my presentation can also be a chance to be honest. Since we are a very small group here, this can open the possibility of speaking about things that are not optimal. I think it's very important to discuss. And as we've seen in many publications, most of the people do better if they see things that fare worse. So the things that have been published to date speak of 400 or 700 millimeters in volume, and the largest prostate that I saw published, maybe we'll see it, the enucleation of 900 grams has been successful, and they have removed the tissue with open surgery, and in my opinion makes a lot of sense. What are the pre-op considerations, the most important ones, and that will be the focus of my presentation? To me, they are pre-op, and they have to do with standardization, what I have just said, an interdisciplinary environment, experience. Of course, you won't start with large prostates when you begin your learning curve, but you have to identify the right time to do it. You have to coordinate the anesthetic team. Maybe it's the same one. If you are used to working with the same anesthetist, you have to guarantee that you have a team in order to manage complications. It means that you are not alone to solve complications. Communication, optimize communication in the surgical team, and that includes everybody, the nurse and the people who close the doors, everybody. The availability of an ICU, well, this is not necessarily the case for every prostate, but if we do prostates above 500 or 600, I think it's better also for the patient to be sure that in case of a problem, it doesn't have to be surgically related. It can be a risk with the anesthesia or a complication because of a comorbidity. Anything can come up, and we have to bear in mind and we have to consider that what we do with these large prostate is the same using an innovative technique, but they can be a higher risk than in smaller. And the availability of a neurosurgeon that is experienced in this type of surgery, the preparation of the patient, the same thing. Do three things, three assessments in each patient, above 200 millimeters of volume, an ultrasound, an MRI, and a cystoscopy, because as we have just heard, the morphology and the anatomy of the prostate can be very different, and the more information we can get before the surgery, the better. The necessary length of the instruments in comparison with Tiago, I don't have the Excel, so I must have everything clear in my mind before the surgery. I mean, how far I can go. The anesthesiology evaluation, and risk evaluation. If the patient is very obese and we create a small perforation in the capsule, it will be difficult to find the necessary information with the ultrasound. And I think this is something you should bear in mind. And arterial hypertension, too. If it is not well, we can have problems during the surgery with bleeding and also after. I always inform the patient three additional things when the prostate is larger than 200: the possible morcellation in stages, the conversion to open surgery, and incontinence that can be lengthy. I think this is something related to honesty. We present cases of prostates that have the size of a bladder, and what are we going to tell the patient? Well, now you have two bladders, but the difference is that the other one has no receptors when it's full. So who tells me that a prostate of 500 millimeters is totally continent? Well, I think everything I hear, but we have to be honest about this. Just considering anatomical changes that have nothing to do with the surgery. Logistics, well, you have to prepare the instruments, of course. We have seen how to use liquids for prostate. We have a large prostate. In my clinic, it is like this, and most the volume is defined according to milliliters per prostate. So if we have three patients above 500, we only do two, or we choose another to meet the 500 milliliters of the weight of the prostate, because if we operate on a large prostate, there's a lot of influx. And I don't know what you do in Latin America. I haven't practically never see it, but we warm the fluid, and we have to warm the whole fluid. And when we have 500 prostate that is 500 gram, we calculate the because the Ranger is extremely expensive. So we always have this armamentarium, which is sufficient for 500 milliliters. In certain cases, the anesthetist can tell the body temperature is very low, we have to end the surgery, or the decision is to end the surgery or a discussion with the anesthetist, and we want to prevent both things. To review the whole system. In any place I say this, it seems banal, but it isn't. Before the surgery, regardless of the size of the prostate, I always test the morcellator. And maybe if we operate many large cases, the best thing is to have a second morcellator and a second handpiece. Or in large centers that perform many cases, maybe you should have a second laser, because I think that this type of prostate should be operated in large centers. This means a large center a high number. Planning the team, well, that is key, and also check that the extended abduction is possible, because when the patients have a prosthesis, you have to consider that in these large prostates we move very laterally, and we don't want to place them in a position that could be cumbersome. We could have organized better.
One slide on enucleation. I believe it doesn't matter whether you do 2, 3 lobes or just unblock. Each technique has its niche, and to me the most important cause is the following. I always want to have several options to come out of this surgery. Just like many of you, I've seen several and every complication. Irrespective of the technique, I always try to develop the floor and the roof, and when I have some sense of what the tissue or bleeding are like, I will move forward. But the most important point of these different techniques is that they have a great influence on what comes after enucleation, which is morcellation. If we have a gigantic prostate, maybe it's not that easy to do what is shown in this picture. I like performing morcellation in the cavity. If I have a huge prostate that was enucleated unblocked, that's difficult. I have to start with the bladder. So what I prefer is having 3 parts and doing all 3 in the cavity, and everything will be okay. In the meantime, coagulation may be necessary during morcellation. Open extraction with a high section, it is also possible, and a morcellation in stages. I learned in a quite difficult case, and this is something that I take into consideration far more than before. Why? There is a study that includes only 9 patients that have investigated the effectiveness of morcellation comparing the same day of the enucleation and 6, 4, 7 days later, and they have found huge differences, 10 times faster vis-a-vis morcellation the day of enucleation. I'm not speaking of these prostate sizes, but the larger ones. We can learn from animals who do it like this, and they get where they want to go. These are things that may happen.
La complicación más frecuente puede
The
ser
most
una
frequent complication may be capsule perforation or puncture, which may appear in one of these places, which is visible here. The most important thing is to know when that perforation takes place, whether it is at the beginning or in between or at the end of the surgery. If it happens at the beginning, I want to be able to come out of it, because what may happen in gigantic prostate is lots of liquid coming out during enucleation and subsequent morcellation. The literature tells us that it is possible and the prognosis is very good, but that's for seasoned surgeons and seasoned experienced with over 200 milliliters. Optimal conditions would be first the patient and not the surgeon's ego. This is very important. You have to reflect upon it, but to me that's the most important thing. And having this into account, I don't care whether I count the number of bilobe or trilobe cases, if it's been to the benefit of the patient, eliminating and minimizing all external stress factors. Teamwork makes the dream work. That's what I said at the beginning. Having a seasoned colleague in HOLEP nearby is always very useful. Being ready for coming out at any time, always consider surgery and morcellation in stages, and be honest and be capable of saying, no, I will not do this with HOLEP. The literature says that what has to happen will happen, and no one is free from complications. Thanks.
Holger, en las variaciones de la técnica, estas...
in technique variations, this initial cleaning you perform of the vesicle neck of the posterior aspect of the prostate, do you do it with prior dissection of the posterior aspect, or do you perform an incision at 5 and 7 as in the original technique? 5 and 7. And up to what volume do you consider using the block technique vis-a-vis a 2-lobe or 3-lobe technique? I do not perform a block above 250. There was a very unpleasant case, 280. And after that, I realized there was no point. The biggest problem with these prostates is not enucleation, it's morcellation. We are tired, it starts bleeding again. And when we look at these data, mainly from this Japanese study or just any other, those who do HOLEP well know how to morcellate quickly, but those who don't at some point start having this kind of issues. So I always recommend, and some tip that you can give us for early apical release. Sometimes when you have a very wide prostate, you sometimes find the plane, but you pull from one side and the other, and the problem comes later when the patient don't have the prostate. So what recommendation would you give us in this regard? Shall we break it in half? Shall we perform a prior incision? Well, I perform the apical release, but I always make an incision at 12 because I want to release the roof, and I have two paths there downwards and on the left and right. That makes me feel safer. And do you consider it in the case of 3-lobe prostates? Do you consider eliminating the middle lobe first to work best? What do you think? That might be a choice, yes, not only because of enucleation, but also because of morcellation. Any other question from the audience? Something else to consider. Conducting morcellation in a second stage. This I have done on several occasions, and I think it is a very efficient alternative because morcellation from 20-30 minutes, it's just 5 minutes. I mean, the time is reduced. Yes, absolutely. And it is not just a matter of technique or of what the instruments we use. It's also that we are tired after a large prostate. If we even if you operate them quickly, at prostate about 300 is a challenge, and to me and to anyone, anything may come up, and we have to be honest. Prolonged morcellation time, irrespective of the technique, it's not just the technique, but the tiredness, recurrent bleeding, all these things which may happen, and we have to take them into account, especially if it happens, if we damage the bladder, even more so. In these large prostates, morcellation is the critical step. Do you set a final timing, or how long do you take in prostates with over 250? With morcellation, you mean? Well, less than an hour. If they are too large, less than an hour. Extend anesthetics, anesthesia. I mean, if you extend anesthesia, all complication risks are increased. And in patients with large prostate lithiasis, what is your approach? Because, good question, the middle lobe does not allow you to access lithiasis, so you have to first perform enucleation and then morcellation. How do you manage it with the stone? Well, I normally remove the stone first.
¿Alguna otra pregunta?
Any other question?
Muchas gracias. Gracias, Juan.
Thanks very much.
Bueno, quedó todo
Well,
preparado para hablar de morcelación.
The stage is set to talk about morcellation, and the morcellation becomes ever more relevant with large prostates. We're going to all go from Guadalajara, Mexico, who's going to talk about advice for morcellation. Thomas, please. Abel Roca, head of the urology ward at the Bolivia ward, and Guillermo Montelesansi, who is Italian hospital staff urologist.
Buenos días nuevamente.
Good morning again. Thanks, Pablo and the German hospital team, for the invitation. We will talk about the non-sexy part of enucleation, the laborious portion, the one that is difficult to conduct after conducting an enucleation. And along these lines, our learning curve in 2012 with Dr. Noé Martinez Juarez is something that I strongly recommend. We divided the procedure. One person would perform enucleation and the other hemostasis and morcellation. This allowed the person entering the operating room to enthusiastic to perform morcellation, to do so more safely, not so tired, especially in initial cases that may be slower and more tiring. First cases where the morcellator were reported by Peter Gilling. He was back then resecting using laser energy, and he came across larger fragments than the resector, and this led them to designing a morcellator introduced through a nephroscope in the external sheath. This is a reciprocating morcellator. It hasn't changed much throughout time. These are some of the morcellators that we have available today, especially in Mexico. We only have the Wolf Piranha and VersaCode by Lumenis and Hawk from Hawk, a Chinese firm. They are the ones that will speak about. The other two on the right is the Jena, which in Mexico is not available, unfortunately, and the good, which was never imported into Mexico, though it's been available for many years now. The most important thing in morcellation is hemostasis. Before we can proceed and start fragmenting and aspirating the adenoma, the most important thing is to have a good field. In our center, at our center, we use the same laser because it is an opportunity for the person who is being trained to be able to approach the resector movements and the distance required to cause coagulation. This is the bleaching or whitening effect that you see in the tissue. It is important to have an order for that coagulation. Normally, we first perform the 360 degrees around the neck, then the verumontanum around it, and then to the back to coagulate some points in the anterior aspect where we release the mucosa. This is a discussion that makes no point. I mean, using a different energy for this coagulation, this is completely optimal. And if this will ensure a safe field for the patient, it's important to have it available. As to the instruments, the only thing that changes is that the external sheath that we've been using should, whatever the gauge it is, in this case it's 26 French, it will be adapted through a device. In the case of restored system to a nephroscope. That change is important. We should make it quickly so that there won't be decompression of the bladder once we have performed coagulation, so that there won't be any bleeding. That change we have to perform in any system or equipment. Now there's specific morcellation equipment at hand. In this case, we are performing dual irrigation. This we no longer do because we realized that the additional system had a little emptying and there was an unnecessary cost for the patient. In relation to VersaCoat, it's a morcellator that has been discontinued. We do have it available, however, and use it every day. It's simple to use. It has a handpiece, a module, and a pedal. In this module, we have just two connections. That's very easy for the technicians supporting us, and two knobs. One gives us suction power, and the other knife speed. In the handpiece, it's extremely heavy. It's the heaviest in the market. It's almost 1 kilogram, and it can be reused and sterilized in any sterilization system. The cost is high, and the knives should be changed every 25 uses as recommended by the manufacturer, so that we may have a more effective morcellation. It's a reciprocating mechanism. It has two windows that meet longitudinally, and with a suction exerted by the system through an integrated pump, the adenoma sticks to the windows and tissue is sectionalized. It's just a single pedal that allows us to be working with suction alone and then push it forward so that we may manage acceleration. This is easy to use for technicians. The only thing they do is put that hose in the roll generating suction. It's technician friendly or user friendly. Aspiration power is 22 milliliters per second, and morcellation has been reported in up to 6 grams per minute. The other piece of equipment available is Piranha, two module equipment, one responsible for knife movement and another one responsible for aspiration. That aspiration is done by generating a negative pressure in a container that is brought to negative pressure. What we do with the pedal is release that pressure to start suction. That is a multi-purpose pedal. On the one hand, we perform suction, and the other, the knife movement. Likewise, we use the instruments used for enucleation, and through the external sheath, we insert this morcelloscope with a hand piece, which is far lighter, a little bit more delicate to use, and with knives that can be for multiple use or disposable. As for use of the system, it's a bit more complicated. We need to have a platform. It says in service, vacuum is complete, as you can see, and at the bottom we can manipulate the speed, having 4 different modules within the range available for the knives. Normally we manage them at 1500 RPM. It's been reported that it is possible to manage 2.5 grams per minute, but the clinical scenario is not the same as the ex vivo one. And if we compare both in a single slide, you can see that Numenis is a reciprocating equipment with a single platform, a single pedal, far more technician-friendly or user-friendly, whereas Wolf is more efficient, but management is a bit more complex. This is a comparison made of ex vivo morcellators, those who were available at the time. VersaCat, unlike others, is not always faster. Maximum speed is 1500 RPM, and that's different in the piranha. The larger the capacity, the larger the morcellation speed. But again, this is an ex vivo scenario. We want to work in this situation. If this is 3-lobe enucleation, we want to have a good field that will allow us not only to see the adenoma, but the neck rim, the vesical mucosa, and to move away from it. We expand the bladder. We want to have the walls separated, and particularly want to perform morcellation inside the bladder because I can differentiate between the tissue I'm morcellating and the bladder surface. As regards some pieces of advice for morcellation, it is important that we have some reference points in our knife so that we know what distance we're working at. Having the adenoma close is complex, it deprives vision, and the adenoma will be morcellated as we allow it to rotate. In relation to Versacat, one of the pieces of advice that we can give is that we turn the hand piece that will allow us to have an oscillating movement and thus improve that system's morcellation capacity. Also, as morcellation extends in time, it's important to relocate the hose because it softens as heat increases and morcellation is less efficient for small fragments. It's important not to chase them. The irrigation that we are having there will move them away. So what we can do is stick to the lateral aspect of the bladder flow will cause the fragments to return, and we will be able to look for them there. Also, it is important to go to the fossa to look for residual fragments because oftentimes there may be fragments there that will block the probe or make patients' spontaneous urination difficult. When we suction the mucosa, what is important is that whatever system we are using, we have to remove suction and little by little handle the knives and disassemble them to release the mucosa without causing much damage. This is a paper reviewing papers on morcellation since 2018 and 2026 studies. They analyze efficacy of those morcellators and safety, and you can see that all these papers tell us what is going on in reality. Efficiency of the morcellator is 5 grams per minute. Efficiency of Versacat is 3 grams, and the efficiency of the other one is 5.3 grams per minute. What is most important is safety. Oscillating morcellators are safer because the posterior aspect of knees have no window, as a result of which there are no injuries being caused. And on the other hand, the Versacat morcellator is the one that may cause the most injuries.
On the other hand, it is important to see that the newer the knife, the better the morcellation, and this is reported by Wolf with the use of disposable knives. The beach ball areas of ischemia in the internal part of the nodule, and what is important here is to see there are risk factors, patients older than 65 and large volumes because of the ischemia and the fibrosis. It's important to know that the beach balls will always delay the procedure, each one about 25 minutes, if we don't take fast measures like taking using the resector to fractionate them, then or take a forceps to approach them. The several urologists were asked their preference about morcellators, and I think it depends a lot on what we have available and what to do when we have no morcellator. Ideally, for enucleation, you shouldn't work without a morcellator, but there could be a scenario in which we cannot move forward anymore with a morcellator. So we could use a technique where we partially enucleate the element or we can fix the adenoma with a forceps and then resecate or do a mini-up to remove the adenoma. There are papers that are anecdotal with the use of gas instead of water to morcellate. That improves the vision, and but the morcellator they used wasn't endoscopic, but it was one for laparoscopy, so the results cannot be evaluated. Also, the possibility of having ultrasound in order to survey the morcellation. I think that is unnecessary if we have an area without a bloodless area where we can see what we are going to morcellize. The conclusions, it's important to know that enucleation requires two procedures. It has its own learning curve. There are different systems with different mechanisms, safety and effectiveness. We have to have available other instruments like a bipolar resector, and we need studies to evaluate the new equipment available, like the new oscillating morcellators. Well, Hugo, an excellent presentation, very clear, very to the point. I have a question for you. You mentioned your preferences to morcellate in the bladder, and you always use the knife upward. Do you prefer to go to the cell or to move the window to the bottom? Well, to the cell, I take an adenoma that is extremely hard, and I need to place it on something so that I can break that rigid capsule that the nodule has. And inverted morcellation I don't do. I lateralize the window when the fragments are very small and are located in the trigon. If we place the morcellator on the side of the window, those fragments flow around and then you can remove them faster.
Thank you very much for a very nice presentation. I think we all learned quite a bit. It's interesting to see that if you have multiple different morcellators, and it's a very nice overview that was already published. But they also always mention one setting for the rotations per minute. And you've demonstrated that there's a lot of settings that you can change. You can change the suction, you can change the RPM, you can change the oscillation speed as well. And do you think that it's sometimes necessary? What's your experience on sometimes needing to change those settings during the morcellations? For instance, when you have beach balls, do you slow down? Do you speed up? Do you change the oscillation? What's your experience?
Creo que la parte más importante es contar con una buena succión.
We need to have good suction, and morcellation means that the tissue should come to the windows that we are using to morcellize, and we have to have high RPM in order to move this complete adenoma. But as the adenoma becomes smaller, you have to reduce the speed of the knife, because that causes the adenoma not to be released, and you have less beach balls. Now we are going to call Tiago J. He will discuss new devices for morcellation, and then we'll have questions. Well, again, I will discuss the new devices that we have available. There are not so many with regards to morcellation. There aren't so many new resectoscope. We have Alfredo who showed us the resectoscope and morcellizer, and we could speak of new lasers. So Alfredo mentioned slim and ultra slim. You can do the enucleation in small prostates below 60 gram. It's also possible to morcellize with a knife that is slimmer, 3 millimeters, but the speed is 1 gram per minute. It's still low. So when patients have a urethra that is very close and we have to use an 18, I try to morcelize with 16. But if the morcellation is too slow, I go in with the piranha or the knife to do a morcellation, a suprapubic morcellation. I will not force the urethra with an 18. This is not for all the cases, because with 22 we used to do all the cases, and we can do it very well. And we can even do it with 26. And there's a possibility to be used with patients that have a narrow urethra and where you cannot use larger instruments. Now, about energy, before speaking of the new possibilities regarding energy, I would like to speak about something that for those who do much enucleation and work a lot with laser is obvious, but not for everybody. So the energy we create is light energy that will heat the water that is in the tip of the fiber. It creates a bubble that will explode and generate a mechanical effect. So you can translate this light mechanically because the bubble breaks, and thermal, and that will be the coagulation. Here I have 60 watts. So all this power will be translated into mechanical or thermal energy. If it bursts more, then well, in one case it will be mechanical, and in the other one it will be different. So the form or the shape of the bubble, and that has to do with the energy. The more energy, the larger the bubble, the larger the mechanical effect. But of course, I will lose the thermal effect, and the length of the pulse, short pulse, like 100 microsecond, the bubble is round, large, that will create much dissection. But if it's 1,000 or 1,200 microsecond, practically there is no bubble because all the power translates into thermal effect to vaporize and coagulate. But then I will have to do a mechanical procedure if I don't have the mechanical effect. And here the same, with 100 microseconds, practically everything is pressure. But if I put 1100 and a sensor in front of the fiber, I practically don't have any mechanical effect. So I will use a quantum system that has 7 different levels. If I use the longest pulse, 1200 microseconds, here I practically the bubble doesn't explode. So the example is the stone, it doesn't move. But the prostate, I won't have mechanical dissection, but all the power creates heat. It creates a perfect hemostasis, at least a good one. And here, this is a slide of Vienna, and the higher energy, it's called EPS. The larger the bubble and the more will I desiccate mechanically, I will lose some of the thermal effect. We speak a lot of peak power. What is it? It's the energy. The peak power is not the laser, it's the energy and pulse length. If the pulse is short, I have a high peak power, but if the pulse is long, the peak power is low. And also the possibility of not being able to choose the pulse length, as Alfredo mentioned. For instance, when I modulate the pulse, either Moses effect or virtual basket for quantum, and if I have a short pulse, I have already the mechanical effect. But the water is as if it were the resistance to light. So if there is no water, there is bubble. Thermal energy will be better in the front, but I will lose some of the dissection. If you are used to performing the surgery with short pulse, when you start with modulation, you say, where is my dissection? So you have to get used also to pulse modulations. Those who are used, you can do a good hemostasis from the beginning, but those who are not, they have more dissection, more peak power. So this is... So here we have the 4 possibilities. I don't know whether the video will show vapor tunnel, virtual basket, bubble, normal pulse, bubble blast. The vapor tunnel, virtual basket, bubble blast, and normal pulse. That's what we should bear in mind when we choose the energy. So if we speak of the thulium fiber, what's the difference? The thulium fiber has a lower peak power, 500 watts. If I use 1 joule, 2 joule, 3 joule, doesn't matter, it's always 500. So the peak power will not be as strong as the helium because it can get to 15,000, but with thulium fiber, 500. So if I feel that I am lacking mechanical energy when I'm using the thulium, I dissect with a tip, and we dissect 70% is energy and 30% is mechanical dissection to compensate the absence of the holmium peak power. And here we have the same. We can get used. We can perform a very good surgery with a thulium fiber. We can use the peak power. Then you can also do no touch, and you can do good surgery with thulium fiber too. The apical release is very precise because the cut is precise. There is no dissection like with holmium. The hemostasis is very good, and you have a clean cut, and sometimes you need to use the tip of the resectoscope. In different studies don't show any difference in irritative or incontinence when we compare thulium with holmium. And the new technologies, the pulsed YAG thulium, the peak power is 3700. It looks a lot with pulse modulation that we have with Moses and virtual basket, but now it's a thulium laser. This has a bubble that dissects, and the idea is to create a hemostasia from the beginning. So pulse laser, like a thulium, but with a peak power that is higher, 3700. Now, what's the new element, the magneto? What is the advantage of magneto? In CyberHo, it's not just the magneto that you will have, but you have 7 different levels of pulse length. So you can have even up to vapor tunnel with 2000. So part of the 2000 created a mechanical energy, so you lost mechanical energy. The hemostasis was not as perfect, and now they lengthen the pulse so much in the holmium that it delivers practically thermal energy. So with the hemostasis pedal, you get a fantastic hemostasis, very similar to that of pulse thulium fiber. But thulium fiber has another advantage. And you know that the continuum chars, but hemostasia is perfect. Here we don't have that possibility, but we have other possibilities. I can use 10,000 peak power when I want to dissect well, when I am used to the mechanical effect of the holmium, but I can use 2,000 in the vapor tunnel and 500 peak power with the magneto. When I say 500 peak power, I mean only practically thermal. Hemostasis is unbelievable. So what should we expect from the magneto now? I think that together what thermal relaxation time changes when we have when we have a place that is hot. If I put my finger and I take it off fast, nothing will happen. But if I leave it longer, then something will happen. But here we have more thermal effect, so I cannot leave it for so long because the pulse is longer and the hemostasia will be better. So it reduces the time of coagulation and increases the certainty of coagulation. I want to distract the vessel without coagulating. but here I can get very good hemostasis. It reduces the need to use bipolar at the end of the surgery. There is a benefit in ancillary surgeries for a resection, a block of a tumor in the bladder. It will be very good, and it also facilitates the learning curve because someone is not finding the focal point, but if the laser is more thermal, it will be easier to find the focal point. And this is a video. There were some vessels that were difficult. It was a very challenging case. It was a video of Dr. Gomez Sancha, and using the magneto, they could perform hemostasis. Sancha always said, enucleation is a true surgery, very difficult even for someone who is as experienced as he. And so we need to show them the important difficulties.
Any questions from the floor? Thank you very much for a beautiful presentation. I'd like to comment briefly on the learning curve. We've talked a lot about learning curves already, and I like the fact that you mentioned that when you're using a new way of using the laser, pulse modulation, going from holmium YAG to pulsilium YAG or anything, it's a new learning curve. You need to find the distance from the tip of the laser to your tissue, and then that adds an extra level of complexity when you move from one laser to another. So I'm very happy to hear your comments on that.
Thomas, what I observe, I teach residents and teach also experienced urologists, and my impression is, I know there is this study from NIKIV saying that it's easier to do enucleation with thulium fiber laser, but my impression is the guys that is starting the learning curve, he wants dissection. He wants a mechanical dissection. So that's why I start teaching with short pulse. I don't use pulse modulation to start because we will lose a little bit of the dissection. So that's why I like the possibility in cyberhole to have a really short pulse, 10,000. You have pulse modulation as you have a little bit of experience, and you have a good hemostasis right now. So that's why I think short pulse helps to see the plane and to follow the plane. That's my impression. I know it's subjective, so that's my impression.
Excelentes presentaciones, Hugo y Tiago.
Excellent presentations, Hugo and Tiago. You showed the difference in peak powers, and that's good. What has been shown before is that there was only 500, not that it could reach 10,000. So this is a laser that will change the system. Do you use it for coagulating? Essentially, exactly. That's the point. We're speaking of magneto. We had 500 of peak power, I liked 10,000, but that's additional to the one of 100, 150. It's a possibility to do more. You can use 2,000, 3,000, 4,000, or 500. That's the advantage. That's the advantage. But since the pulse is too long, it is not yet possible in the 150 watts holmium to have more than 30 watts power with the magneto mode because the pulse is very low. So performing whole enucleation may be possible, but that's not the objective. The objective is to remove stones and hemostasis during complex enucleation. That's the point of magnetotherapy, not do a whole of the enucleation with magneto, but with the basket, and then coagulate the most difficult vessels, the mucosa, the neck, with the magneto. Since did not allow us to ask questions before, I would like to know what to do with incontinence. If you have used physical therapy in some patients, because our elderly patients cannot urinate. They have no muscle, they have no accessory muscle. And in my practice, since I've been working with physical therapists, the situation has improved significantly. Well, first point, we remove the sphincter from the prostate. And if I look at the European guidelines, 10% of patients post-open prostatectomy had temporary incontinence, 10%. So that's one complication of enucleation complication, but also of this other surgery. Resection to 3%. In the 90s, the Hasweiler study showed 30% incontinence in temporary resection. So 30-60 milligrams improves a lot because in the uretrogenic incontinence, the bladder contraction because of the presence of urine. I also recommend physical therapy 2-3 weeks later with electrostimulation. The upcoming module is on incontinence, how to prevent it and treat it. One more question.
Bueno, nada más en relación a la incontinencia y
Well, in
factores de
relation
riesgo.
to incontinence, there are risk factors which are larger volumes and elderly patients. In our group, we review pelvic floor before surgery. We want the patient to have mobilized the pelvic floor before surgery and immediately after the catheter removal period, that they know how to perform the exercises. In that specific patient group, we perform pre-op surgery. And as to equipment miniaturization, what is the limit and volume that will make you say, well, that's how far I will get with this equipment. For 22, there's no limit. You can do all cases with 22, but sometimes you lose sight because you are if the neck is too high in a 200, 300 prostate, you may break it, but it can very well be done. In the other one, 60, 80 grams, you need exposure to dissect. So in addition to, above 60 is too difficult, but 22 won't change. And morcellation, that's terrible because the vision of 22 is like fiber optics. To create a 5mm channel to pass the knife, you have to change the lens system to a fiber optic system. And vision is reduced. Now they're developing a system with a chip at the tip at prostates with 200, 300. Morcellating with 22 calls for more attention, and you are more nervous because vision is not that good vis-a-vis the 24, 26 lens.
Bueno, muchas gracias a los oradores y al panel.
Okay, thanks very much to the speakers and the panel. Dr. Rodrigo Melorio is going to show us an in vivo surgery. Germán Ramírez Wesluc, urologist from the Garcia Salinas Hospital in Trenquilanque, Saúl López Ramos, urologist from the San Ignacio Colombia Hospital, and Rodrigo Juaneda, uro-oncologist at the clinic in Córdoba. I now pronounce your surname properly. I had misspelled it before.
Bueno, buenos días a todos.
Good morning to you all. Pablo, thanks for allowing me to participate in this activity. I was asked to speak about tips and tricks for bipolar prostate enucleation surgery, and I had my presentation ready. Let's watch the surgery. I will want you to intervene to make it interactive. They're short videos, but there are certain things that we have to underscore, and it is good that we have this instance for it. It's like speaking of Cinderella, bipolar enucleation is like Cinderella. We are looking at high power lasers, equipment miniaturization, and this is a type of surgery where you have to be enthusiastic, thrilled, and then doing it is quite simple because the equipment is little. If it is not available, if you are in the provinces or you are a resident and you want to start progressing with the enucleation practice, this is the best option. This is an evolution of a BTURP surgery patient resident may be ready to start with this after a few cases. It's flexible in that you may start with the middle lobe, then resect the rest. So at the end of the day, it is a good instance to approach enucleation. This Cinderella is looking at herself and says, okay, let's get started. What we need basically is this Stort, which is fantastic. It allows cutting, coagulating, pushing. It's highly resistant. The strength is very good. Maybe not at the beginning, but once you have a little bit more experience, you can do 30, 20 procedures with the same, and that saves a lot of money. Today they spoke about the urethra, and miniaturization of equipment goes along the lines of caring after the urethra. I use meatus dilators, I use an Otis ureterotome when the urethra is stiff, an optical obturator, which is a fantastic tool, especially to go past the vulvar urethra area. And you see the instruments here. This is what we use for an RTU with some additions. And this is the image that we're going to interpret as our finger. Contrary to the no touch of the laser technology, bipolar enucleation surgery does require for this type of dissection maneuvers. This is basically to know that there is support in the literature in relation to the various enucleation techniques. So let's, shall we say we cannot start with this? Yes, we can. And well, maybe we have no money or no technology, but we have experience in different studies that ratify that the improvement in IPCS, quality of life, residue, etc., is comparable using bipolar energies and the other lasers available on the market, even if we compare it to minimally invasive, robotic, or laparoscopic adenoma surgeries. Cinderella starts getting dressed, and this is a paper that basically defines the unblocked enucleation technique with early apical release. Today, 70–80% of my procedures involve the use of laser, but when we started, we only had a bipolar one available, a 30-watt holmium laser, which was no good for large prostates. We adapted the technique, and I follow the same steps, both in bipolar and laser surgery. This is the main thing, how to release the sphincter. This is what will then affect the patient's perception about the quality of surgery, that's for sure. Let's show a video. It's not been edited, so that you see a few things that will help us identify the landmarks, see where to go, and what to do to release the sphincter. At least how I do it. Doesn't mean this is the only or best approach, mind you. I've entered the bladder. I try not to split the mucosa. Sometimes you exert too much pressure to access the middle lobe, and you can tear the mucosa. I use a Collis. German does not use it, for example. I think it is important because what the Collis allows, as you will see, is profoundly mark the mucosa. There are some hollows there. When you see them cut there, that's the place where you will surely access the prostatic capsule. It's a profound cut. The idea of this deep cut is basically that when I start pushing the adenoma, the mucosa surrounding the sphincter will be already released. Maintaining continence involves mucosal coverage of the sphincter at the end of the surgery. We're not going to tell the sphincter cutting it with a bipolar laser, but we can remove the mucus cover. This may be discussed in the upcoming talk, but a sphincter may press the mucosa, and it's very difficult for the sphincter to press upon the fibrosis. We introduce this, And as you will see, since I have the mucosa already released, the pressure I have to exert is minimum. That's it. I have the capsular plane. So it's not limiting, it doesn't have to be frustrating, just as a matter of patience. If you're in the prosthetic tissue, will go further down until you reach that plane. As I move forward on the side aspect, first always place the sheath, and then we're using the resectoscope as a finger, and I have no mucosa outside there because I left it behind because of the profound cut I made at the beginning.
Hago lo mismo de ese otro lado.
Same thing on the other side. When I performed the cut, I respected hour 12 in the mucosa. That's arguable. In the past, we all did it. Now I have stuck to it because I do well. The trend is now to cut the circumference. It's a matter of preference, I think, but by pushing like this, I'm luxating the side aspect of the apex, and I will be more efficiently be able to preserve the apex mucosa. As my colleague said, the sphincter has more proximal vis-a-vis distal positioning. And what you see there is the mucosal bridge with the side aspect of the apex already luxated and I cut. And with that, what I do is ensure that the side cover of the sphincter mucosa is respected, maintained, and that the apical or cephalic coverage of the sphincter is also maintained, a bit redundant with minimum residual tissue, which hemodynamically speaking will not affect the patient's post-op flow. Any comments? Rodrigo, you are seasoning both techniques. Why do you do 30% with one and 30% of the other? The place where I am based in Uruguay, the work system involves working at different sites, different hospitals in Rocha, where I carry out this surgery most frequently. I do not have a high power laser. I use a bipolar and also in Montevideo, where I do have high power laser available, I use high power laser. And in the case of OLED, do you perform a morcellation there, or do you resect it? Not. Morcellators are portable. They are heavy, but they can't be carried around. That's another thing. I don't believe, especially for residents who want to start with this, I don't think it's a limiting factor. Actually, when we didn't have morcellators and started with the technique, we performed the unblock release, and then we performed a small fan, 2 traction points in the bladder. We removed the adenoma with the filter through as small a space as possible. And generally speaking, we could remove the catheter 48 hours later and never had any issues. So I truly believe that starting with this type of surgery is not costly, it's affordable, and this transforms this into a motivational talk. Do you have any volume limitation for the bipolar? No. No, I have never come across prostates exceeding 300 grams. Well, because much was said earlier about high volume prostates. I haven't seen them. There are none in Uruguay, or at least not that big. Generally, it's true that small prostates are very laborious when it comes to operating them using a bipolar. In the case of a small prostate, there's no point using this method, and now that I use both techniques, sclerosis of the loja is far greater in the case of the bipolar one vis-a-vis the use of laser, maybe because of a matter of energy release and traction. But this we can do with anything else. I think the video is repeating. So once we have released the sphincter, we win. We win. Why? Because everything that comes afterwards may be a little bit or more or less cumbersome, but the end result of the surgery is confirmed and it's guaranteed. Whenever there are residents, when we are at a university center, it is important to know that this is the most important step to mentor, and then you can be a little bit more flexible. A second step is accessing the adenomas anterior aspects. That's a very nice step. Generally, we go to a place where there are no major inflammation issues. You may coagulate very well. And let me tell you something, for those who have nothing to do with urology and who watch the surgeries, the bipolar enucleation surgery, they like best. They see the planes, they see no charred sectors. It's a surgery that I'm very happy about, and I defend it with hands and feet, and I encourage it. Also, seasoned surgeons will tell me, well, there you go too far up. You will end up in the rectus. The caution here is to aim downwards, to go to the vesical head at age 12 and not necessarily dissect upwards. That's a precaution, which is the precaution you should have at this point in time. How long do you leave the catheter? In the case of the bipolar option, 36 hours. It's not well regarded for ambulatory patients to leave the hospital on a catheter. It is considered poor technology. So we have 36 HOLEPs for bipolar. Well, we have released the prostate in the apex. Now we are going to release it in the posterior plane.
I do this plane first. In laser, I do this systematically. I release the posterior aspect. I move to the sides to have a clearer 3D idea. With bipolar, it depends on the case. It's a step that you interrupt. There is an interruption of the capsule because of inflammatory process. You have to struggle to keep in one plane, because you have to get the right plane and be there, stay there. So we have to progress in a horizontal manner. When we get to the bladder neck, it's no longer anteroposterior, but it will be vertical to release the mid-globe from adhesions.
No sé si tiene algún comentario.
Do you have any comment? How did you evolve? First with the Bipolep. At the beginning, it was a matter of need because we didn't have a morselizer. It took us a long time to get to us. So we tried to do the mushroom technique, and that's how we operated on our first cases. And then when you have the morselizer, it's a totally different story. That's an important step. At the beginning, we all started without having a laser, and we did it like that. But we would do morcellation in situ. What is the main difference, Rodrigo, between the HOLEP and the mini HOLEP? The main difference in the intra and the post-op with regards to incontinence and bleeding, what would you say? And if there is a technique that is simpler to learn than the other, if you had to establish a difference. I transitioned from seeing a laser surgery adapted to bipolar, and then I transitioned to the laser. I would say that you see how you dissect the anterior aspect, the passage to the sphincter. It's not complicated if you do it carefully. Of course, the more cases you perform, then the faster you'll do it. But you shouldn't fear it. You have to have patience and be confident and not frustrate yourself. Once you master both techniques, I would say that bleeding is more or less the same, irritation a bit more in the bipolar. In terms of continence, if you respect that, it doesn't change. As long as the surgical time is reasonable and there is no excessive traction in the sphincter, because you move the machine quite a bit in the sphincter depending on the width of the prostate. So different steps help you perform a good surgery. When I started, I dissected the whole prostate. I opened the abdomen to remove it because this last step is quite demanding, and if you do not practice it from the beginning, it becomes cumbersome when you release the midlobe in the subtrigon area. I think that there are a couple of details. One, that the lateral incision should be broad on the lateral aspect of the prostate. The worst thing that can happen is have a large midlobe and have a very small neck opening. So you have to take the time to make a good lateral dissection, get to the lateral mucosa of the neck. That is very important. It's key. Have a good hemostasis. You'll see that all the time I am pushing the tissue.
Capaz que. Bien. Me bloquearon. Pero bueno. A ver si aprieto vuelta. Uy, fui para. Perdón. Bueno, no quiere el lóbulo medio. Pablo, no sé si está. Ahí estamos. Ahí va. Entonces lo que hicimos ahí fue básicamente.
What we did there, basically on both sides, we dissected laterally but broadly, and in the end, we devoted to the 6 o'clock of the midlobe. And if you don't practice this from the very beginning, then when you get the morcellator and you start with this step, you sort of go back, and the small fan still doesn't change too much the patient's evolution. There I'm cutting the mucosa that is well below the midlobe. That's the meatus, and I am moving very close to the midlobe. And I have 4 instruments to have access to the urethra. I never have a stenosis or stricture of the urethra, but I do have a sclerosis of the loge in small prostates, and I had some problem in small prostates with bipolar. You can solve that later, but why what many do is after HOLEP they do hemostasis with the bipolar, and in this case you said that for us, for you, bipolar has a bit more bleeding. That would be the opposite thing. Why do you think it's that? So enucleating with bipolar, you have a bit more bleeding than with the laser. I don't use bipolar after the HOLEP. I think that very probably what the bipolar does is that some veins that we cannot see, probably closer to the bladder neck, and that is what bleeds a bit more. But with a laser, you coagulate the vessels better because it's an anterior trigger. You do a hemostasis, you do the hemostasis of the larger vessels, but the difference in general is
Last year, they compared the different energies because enucleation can be done with different energies depending on what you have in your clinic or your hospital. But since the results are maximum flow, IPFF, incontinence, they are similar after both. So let's start with enucleation surgery, and you should know that in the Urology Academy you can find the videos not edited plus the videos from of other experts, and that's it. Thank you.
Perdón el tiempo.
Gracias, Rodrigo. Muy buenos videos.
Thanks, Rodrigo. Last module.
Más temor en esta cirugía, que es
And this is what we fear the most, which is incontinence after HOLEP. And we are going to call the moderators, Dr. Gisela Enz from Ramos Mejia and Dr. Matias González from the Italian Hospital. And the first talk by Dr. Alfredo Sanchez, a urologist, how to prevent incontinence post-procedure.
Nuevamente, buenas tardes con todos. Gracias por estar presentes.
Well, once again, thanks for being here. We'll discuss a topic that has been discussed throughout the morning, and it's important. I always show this slide in my presentation whether there are contraindications in the HOLEP, and if there is one, it's urinary incontinence and a patient who has high expectations with regards to continence. That patient, probably for that patient, you should offer a different surgical option, because we always speak of sexual function, preserving the ejaculation and preserving the erectile function, but guides practically don't speak about this. So when you have a patient with high expectations about urinary continence, you have to offer them a different treatment and the one you manage the best. Why? Because it is complex how the mechanism of the sphincter functions. It has already been described this morning. There is a mucosa you should preserve. You have to differentiate the sphincter from the mucosa and the bulbar urethra, and how the mechanism works. They are different and they work differently. And you should also consider how the apex is implanted. Mariano has already described it, and the MRI has helped a great deal in that sense, because each membranous urethra has a different length. So there is a spectrum of patients who have whose prostate grows, but we know that not all large prostates create LUTs, and that a small prostate will not generate that. So before taking a patient to a surgical decision, you should look at the spectrum, both in the prostate and the bladder. And these are the guides, both the Europeans and the American. And HOLEP is the treatment option for all types of prostates. The American guidelines focus more on the size. The European guidelines speak more of the risk for the patient, both in coagulation and in the effect of anesthesia on the patient. And there you have a square that says what happens with patients with high expectations, that we should offer them a miss. But none speaks of continence, and that's what we are going to discuss here today. Why to choose an anatomic endoscopic enucleation of the prostate? Because it will help in the urination of the patient. It will preserve the function of the detrusor that is affected. It will improve the contractility of the detrusor. It will offer the greatest benefit because it reduces the urethral resistance. The patient
even if having a hypoactive detrusor, can urinate because of the amount of tissue we'll remove, and it also reduces or slows the aging of the bladder. So we not only remove tissue, but we also need to understand the urination dynamics of the patient. What are the phases of that muscle or the bladder, and we should know that there will get to an irreversible point. Even if we offer a surgical treatment and we are the best surgeons and our technique is the best, the patient won't do well. So I think that we should reconsider the indications for prostate surgery and not delay them and not to take a long time to indicate them to the patient. These are the apex. Type C is the most common one. This has been given to us by our radiologist friends, and we identify them very easily with the advent of MRI, and we can request an MRI prior to the surgery, not routinely, but a patient with a large adenoma, in order to know the length and the type of apex that we are going to face. And someone asked whether you send them to pelvic floor therapy before. It has been well described. Dr. Kegel did it, and we know that that helps a lot to the continence pre or post-op. And patients at risk, obese, hypertensive, diabetic, smokers, hypothyroid patients, you should maybe send them to physiotherapy of the pelvic floor before or after. But radiologists don't know this. We sometimes don't. We have to understand the endoscopic anatomy of the prostate. The internal sphincter is important for continence. Prostate is important for continence because it is part of the mechanism, and we are removing anatomically all the tissue. And if we have a sphincter that is hypotonic, hypoactive, a patient with a lengthy catheter, probably the patient will end up with incontinence up to 3 months, and there we have to tell the patient that they can be up to 1 year like this and they won't improve. So if we don't understand the dynamics of continence, it'll be difficult for us to offer safe surgery, avoiding to damage the quality of life. It is a lot is said about the torque and what happens to the mucosa after an enucleation and the repercussion it has in post-op continence. Beware, because sphincter mucosa is one thing and sphincter is a different thing. If sphincter ends up like this, you'll probably have incontinence. Even more so if the lesion is lateral, which is the one that affects continence the most, or at 12 o'clock, and we'll see how to prevent it. And we have to differentiate that from the mucosa. So you have to have very clear in your minds not such an aesthetic aspect of the mucosa at the end of the procedure. The torque is important, yes. Mariano said that the patient has to be well positioned. Sometimes we exert much pressure. When you move the equipment inside the patient, you have to be very careful. The catheter is the probe is flexible, but the equipment is rigid, and every movement we perform will create pressure on the sphincter and the urethra. So be careful with the movement, how high you place the table, and how you separate the pelvic limbs of the patient to prevent touching them and creating much pressure. Patients with a broad perineum, yes, of course, they have more torque. In this patient, the probe is inside the urethra. Practically, there is no probe outside the meatus. Look at here, the mucosa, when you do release the apex, and look here at the end of the surgery. The patient will have good continence, but that is explained because we have created more torque. Or we have heard of long or
broad prostates, but what happens with high prostates? These patients have high prostates. You have to, and gaining access to the anterior plane is difficult, and you'll see that at the end, this is a high prostate. You practically have to do this movement in order to get to the anterior plane. Careful, patients with a broad perineum are more delicate when you move inside the urethra. My lab, it has, a lot has been said about it, but Tiago said that it is improving, the vision is improving in reduced tract equipment, windows are different, and the irrigation system in the tip are different that can protect the mucosa, but it doesn't tell us that the continence will be appropriate if you do not respect the steps or don't perform the procedure safely. Regardless of the instrument, the result will be the same. Do you use the Otis urethrotome? We do. It's a very thin cut in the mucosa at 12 o'clock, but it allows us to have good access when we do not have sometimes available a shorter tract or a miniature equipment. So this is a good tip that I can share with you so that you can use it in your clinical practice. What is our purpose? Well, here I wrote, I am showing two videos where we can see the final aspect of the mucosa. And this is very important. Just as we are going to protect the sphincter, the external sphincter, it is also important to protect the internal sphincter. Look at the two aspects of the mucosa, both on the right side and on the left side. They are different, but the patient will have perfect continence in both cases. In one, aesthetically, the mucosa is more damaged, by the closing mechanism will be the same, probably because the apex was implanted more posteriorly or the prostate was high, so it will be very difficult for us to have a perfectly preserved mucosa or nice, as you see sometimes in the videos. That will not always happen, so don't get carried away by that, so that the final aspect will determine the continence. That is not always the case. This is important.
Activating the neck is important. He recommended expanding the neck. I think you don't have to be too aggressive here because this is part of the vesical continence. You have to open the vesical neck just as necessary to remove the adenoma, prevent neck fibrosis, and we do not have to invade it excessively and lift a narrow or to tighten neck that will cause sclerosis and urination problems. By leaving it like that, our patient will have better continence. There are patients who tell us, well, I can urinate well, I have good continence, but they move to the two-step position and they have leaping. That patient was perhaps, the neck was too wide and the external sphincter has no sufficient pressure to withstand all of the weight of the urine in the bladder. We have to protect the sphincter mucosa and the sphincter. This is a video where I will show you my strategy. When I enter, I identify the sphincter, but I do not go to our 12 with equipment. I try to launch the fiber. And if it's not sufficient, you see, I could not go to 12 because they had told us that the sphincter was like this. This was the arrangement. So first I start cutting at the bottom. You will realize how little by little the 12-hour portion drops, and it's more accessible for me to reach this area as a surgeon with high wide perineum patients. It's much easier for me to reach our 12. It's far more comfortable because if you try to reach that point initially, you will cause a mucosal split at 12 and you will see it torn. See how easily I get there, but I launch the fiber, not the equipment. What I'm launching is the fiber, and I will progress millimeter by millimeter in order to obtain this result. You see there the inclination, which Tiago was mentioning, and that other speakers mentioned as well. It is inclined, and how we can manage it correctly, we do it this way. This is something I have shown on purpose. I move back, see the symmetric implantations of the apex. It was an asymmetric apex. I move backward and forward again. See, here we're going to see the sphincter. You see the sphincter, it's preserved. And what is ahead of that is the sphincter mucosa. Even though it helps or contributes to continence, if you respect the sphincter, you might have adequate continence, even if the mucosa is not as aesthetically or visually nice as possible at the end of the surgery. Nonetheless, they will have adequate continence. You have to differentiate both things. Last year, I was here talking to you. We talked with Carlos Ameri. We said we are responsible for not bringing the patient to surgery with small adenomas. It was an 8-gram prostatic adenoma. See the post-urination volume, which is high. It's our responsibility because it's us who dilate surgical indication. We wait for the patient to have some absolute indication for surgery, but look at the bladder, it's very much affected despite this being a small adenoma. So it is our responsibility to talk to the patient, tell them that they are going to benefit from surgery and avoid prolonged treatment options, irrespective of age, because there is a healing window. After a certain time, the bladder gets upset and will not improve. See, in this small adenoma, we reached very well at our 12. We did not need to start from the bottom. We went up directly. And in this kind of adenoma, you can preserve the vesical neck very well. And even in these patients, I can identify my plane from the apex. I know there are different approaches, lateral aspect right in front of my plane there can develop little by little. And lastly, we have made the early apical release, which is the critical point for enucleation, the most difficult to understand. We preserve the neck. We do not have to open it more or less, just as necessary. And then it will be very easy to make the adenoma turn to the bladder, and thus we will be protecting the external sphincter, the sphincter mucosa, and the internal sphincter. That middle lobe would never respond to medical treatment, and we do not have to postpone this type of surgery. I recommend that you invest in training and certification, see experts, go to high volume centers. There's a Mariano Gonzalez who perform many surgeries a week, not only to see what an expert surgery is like, but to witness the OR environment, the post-op. Now you have access to everything, a simulator out there. And the first video on the right, this is being done in Chile. You have these simulators which are spectacular. There's a rowboat. So you have to invest. If you want to offer safe surgery to the patient, avoid incontinence, which is a nuisance. Fortunately, the incidence is low, but same with sepsis in percutaneous surgery, the incidence is low. But when you have a patient with incontinence, it will be highly upsetting for the patient. For the patient first and for you too. The patient's quality of life will be affected, and that's shameful for us as urologists. If we perform the surgery, the patient should improve. So there's no point in a patient urinating like this after HOLEP if they will have to use diapers after ending urination. So HOLEP is not just for this obstruction purposes. We have to care for their incontinence. And something important was said when talking about the leadership talk in social media. There appears as if there are just two techniques, HOLEP, aquablation, but there's also TERP. Dr. Marina Castillo shared his experience in Cuba. There are different realities in Latin America. There's heterogeneous experience. So we have to start talking about reality, what we are doing, how we are facing it, and not get carried away by what social media say and imitate that. Let's tropicalize our reality in hospitals and let's perform safe surgeries that will improve the patient's quality of life. There's no point in me performing a whole lip with high power laser if then the patient is going to wear diapers. Thanks very much.
¿Alguna pregunta, tal vez?
Any questions?
Bueno, y ahora, si no funcionó todos los tips que nos dio el doctor,
all of these tips failed, Francisco will tell us how to treat patients with post-HOLEP incontinence.
Bueno, ya llega el almuerzo. Me toca la última. Vamos a tratar de hacerlo dinámico y rápido.
Let's try to make it dynamic and quick. We're going to skip the introductory slate. The idea is to enucleate no matter the energy. We have talked about this. There is historical evolution, what energy we require, and we always want to do well. And terms are coined which simplify things. This is a trifecta, that is a patient with no incontinence, with flow and no complications. And there are others who speak of the pentafecta, adding to that fast surgery less than an hour, not using a resectoscope. That will not necessarily contribute much to the patient, but it's for you to understand what we are looking for when we are performing this surgery. There are post-op complications. We speak of incontinence, but it can also be bleeding, urinary retention, urinary infection, dysuria, pain, urethral stenosis. But when speaking of incontinence, transitory incontinence, much has been reported, but it goes between 6 and 53%. And persistent incontinence, there are several series that report 0. 0 is a figure that may sound unrealistic, and it's 0 to 6%, which is higher than you would find in the larger series. This is the one that I like best. It's the real-world information. 6,200 patients operated on by expert surgeons, and globally they report that out of those 1,600, 15% interim incontinence and only 2% persistent incontinence. Why is this important? This is what we have to tell patients, that even major experts do have some temporary incontinence rates, which is not minor, 15%, and persistent incontinence too. There are many factors which have been studied in relation to incontinence, both pre-op, intra-op, post-op, and there are meta-analysis and network meta-analysis that speak of analysis of these things. We won't go into details of the curve. Someone has analyzed them already. The only thing they have found, linearly speaking, is a patient's age, prostate size, surgery time, and laser time. What can we say? That's the time we are inside the urethra. The longer we are in there, either because we used the laser a lot or because the prostate was large, that's how the probability of post-op incontinence will increase. That's a linear increase. To look at the curves with the different types of power, they all have the same slope. More volume, more time inside the urethra, the larger the incontinence rate. Same with temporary or transient incontinence, but we do not reach a significant peak. But in patients with larger prostates, the temporary incontinence rate is higher in relation to time. Scores have been developed in relation to this. One is the patient who is going to be operated on, what we can tell them. Management expectations is very important. This has been said several times, and we do have information. This is a chart, but that for those who do functional urology is well known. That's the upstream. We have predictive success and failure factors. Failure, how the patient will do after surgery. What have we learned? That in an elderly patient with comorbidities and with feeling symptoms will have a greater probability of not doing so well with the surgery, whereas a patient with lower Qmax, not so elderly, with not so many feeling symptoms and fewer comorbidities will do better. This is the literature, so we need to manage expectations. Urgency symptoms have an uneven response. Many persist temporarily, but we have to tell the patient that probably the urgency will continue for some time and that these things will revert after removing the obstruction. If the patient had urgent incontinence, we have to manage them as we did before surgery. There are guidelines which are practical in terms of the lines. I like the treatment lines. Now, this is not so much in use, but basically the option of medication, Botox, neuromodulation, intra-op. This has been already mentioned, so we'll skip some slides. Also, there's the technique and the tools that we are most familiar with. We have to perform surgery as quickly as possible and with a team and equipment that is ready for. And then the critical moment, post-op, the patient comes to the first post-op visit and says he has leaks. Much of the information we have on incontinence we have taken from other surgeries with a higher incontinence rate and with which we have most experience post-radical prostatectomy, continence recovery over time. This is a curve taken from the American Urological Association. It worsens initially, then after 6 to 12 months, we reach a plateau in either continent or incontinence. So we have to tell patients about this before surgery, and in the case of incontinent patients, tell them about this for them to know that this may improve, that it takes time, and that this improvement may continue well past 6 months after surgery. So what do we do over those 6 months? Well, first, conservative management. Physical therapy, pelvic floor exercises are tools that have been mentioned already. Patients who had urgency symptoms and which we detected incontinence, we will manage them with medication. Also, the third line of treatment, which is Botox and physical therapy, and also duloxetine. There's evidence that might help if there's good tolerance. That's not mine, right? If there's good tolerance at 30 milligrams, I will increase it to 60. But the response rate in some patients, the literature is 30 to 80%. In my experience, not 50% of significant improvement. As for physical therapy, we have dedicated professionals that engage in recovering the pelvic floor. Biofeedback and electrostimulation aim at the same, but with the devices to have full awareness of how to reinforce the pelvic floor, and that transition may be part of the improvement and the improvement in the muscle tone. And we have to perform regular checks. We do not want to see incontinent patients because it reminds us of something that we don't want to happen, but patients need that support too. And then the most critical point, 6 more months elapse and they still have leaks. So we have to rule out these patients. Do not differentiate when we ask them when it is that they have these leaks. They say all the time, because for them it's all the time. When the urgence, they want to urinate before there is any leak, it's not clear. A urination diary helps us a lot. There's large volume with frequencies that are quite high. So this guides us. Questionnaires help us to ascribe a figure to what we record in the case history. Also, the number of pads used warns us about the seriousness of incontinence. We have to weigh the diapers. Patients change diapers just because of one drop, and they change diapers excessively. Incontinent patients are, and their quality of lives are affected, and they think that just one drop of urine means smell all over the place. So we have to take this into account. And this score is the MSIG is having the patient standing. We make them cough to see whether it is leakage all the way through the cuffing, if it's just one drop or a jet beginning to end. It's an assessment of what we see in the clinical examination. When we reach that scenario, we basically have to accept it. Sometimes we are reluctant and insist on conservative treatment, but we have to accept this is not the case, and sometimes refer the patient to an incontinence expert. We must have one handy, such as is the case with reconstructive surgery, and start offering different treatment options. The PAD test is a diaper test. If remember the pediatric residents, well, ideally we should perform the 24-hour one, even though it's more cumbersome. Weigh them, differentiate them. For practical reasons, I use the 1-hour test because it can be done at the hospital. And if you do not have a scale at home, I have one at the hospital. This is stereotyped. I have the literature. I can tabulate the incontinence into mild, moderate, severe. What is the leakage amount with this type of activity? And then the checklist. I have come to a point where I can offer the patient a procedure to improve incontinence. What do I need to plan it? The urethra must be stable and intact. Intact, there's no stenosis. Even the patient comes to us and we find a neck stenosis. So we have to treat that first and then think of treating incontinence. Unstable because oftentimes after finding the stenosis, we treat the stenosis, but the patients experience a worsening of the leakage symptoms, and we have to wait a few more months for the urethra to close, and also the urodynamic status. In the past, we said excluded patients who had urgency, but where the urgency incontinence we think is the main reason. But not necessarily this is the case. They coexist. There is a recent paper that says that patients with hyperactivity have good results with anti-incontinence surgery. It's not related to urgency. With all that information and with the PAD test, I managed to tabulate it and then have to get to know the patient. I have to know what the patient's cognition status is. These are elderly patients in general and who have good dexterity. I can use the artificial sphincter. They need to have a good dexterity to touch the scrotum bag, empty the bladder, and have a cognitive condition to remember that they have the sphincter and empty it that way.
And expectations are also important. What does the patient expect and what risk does he want to face? Because sometimes they want to lower the risk but meet their expectation. And about treatment from less to more. Here we have in Argentina, we have the macroplastic, we don't have a lot. And what I create is a bump in order to close the urethra a bit more. As global success rate, it has 20 to 50%, including retreatment with more than one injection. The other option is the fixed sling. It's good to understand the mechanism. What I do is I reposition the urethra. The image that I show the patients in the cystoscopy I showed as if the sphincter would not have a full coaptation, and I push from below and I get a good position for continence. So a test of repositioning with a cystoscopy, I look at the sphincter and pushing externally the perineum, I see if the motion of the urethra is right in order to see whether it is effective. That increases the rate of success. The advantage is it doesn't change the habit of urination. These are images of the surgery. This is a perineal incision, not very large. We identify the urethral bulb. We release from the central tendon so that it is mobile, and with 2 needles, what we do is we fixate the mesh, and after that, you see that there are 2 images, one by the other. The right one is after the positioning. You see that the bulb seems to disappear. This is what the mesh does. It elevates the bulb in order to improve the position. As for evidence, there's a lot of evidence about therapies, but not specifically targeted to post-enucleation. So we have evidence of few cases, 3 in this case. They did well, but they are retrospective and they are small. The same principle of placing a suburethral support, but it allows to adjust. The atoms is basically a silicone device that I can inflate and deflate with an overall success rate for the 3 between 50 and 70%, 75%. The remix is a similar mechanism, but instead of fixating through the transobturatrix, we go retropubic, and we can have more or less tension on the urethra. And this is a recent launch that was developed here in Argentina. Matthias worked in it. It's a suburethral support or sling with a retropubic elevation and a scrotal access port to insufflate or deflate that device that can support the urethral bulb well. And now the gold standard, what is it? It requires manual skill because it has a pump, that you see there, and the pump has to touch it when he wants to urinate. Of the 3 components, I play 2. This is like the sheath. And you take a measure to understand the size. Not all the bulbs are the same. And that is what remains closed all the time. And when the patient wants to urinate, he touches it. This is the passage of the first component towards the upper incision. There I do all the connections, but in the scrotum, what remains is there, that is a component of the pump. They have to touch it when they want to urinate. Then that sheath opens up, they urinate, and then it closes alone. So they have to understand that they have the sphincter there, and the success rate is the highest, but the revision rate is the highest too. I have 3 components there, and they have to move the fluid between the pump, the sheath, and the pump, and the pressure. Now, it's not a lot that has been published. This is a presentation at the Mayo Clinic of cases they treated for incontinence after enucleation. 10 slings and 10 sphincters, follow-up not too long because its mean is 1 year, the maximum 55 months. They had already 2 revisions, so I have to revise a component of the sphincter to exchange it, and the other had a second surgery. To summarize, this is much information of several treatments. I have to divide them in mild, moderate, and severe. There are treatments in which I can foresee the probability of success, but also undertaking the risk. If the incontinence is very mild with a score that is difficult to identify when the patient is standing, the patient is not ready to undertake many risks, so I will move towards the left, and the fixed sling are the ones that can offer an appropriate result with a rather low risk. We measure the success of continence in different ways. For us, success is social continence, and social continence is that they use one device during the whole day. For us, it's okay. Maybe for the patient, it's not okay. So that patient wants something that is not easy to attain, and sometimes we have to resort to more invasive procedures, but the success rate will be higher. So sometimes it's a long discussion with the patients for them to understand all these options and their pros and cons. For mild to moderate incontinence, fixed sling and adjustable sling what we get is a good balance, because these patients that go on a benign and scheduled procedure, if we change the urination pattern with a sphincter, is something more difficult to accept. Now, for the patient who undergo cancer surgery, that is different. With adjustable sling, we can use them too. For mild to moderate, the fixed sling is a very good option. The adjustable, we have a body of evidence, a growing body of evidence that it can be used in severe incontinence, and the sphincter is the one that has the highest probability of success, but there are also more probabilities to revise. In figures along 10 years, practically 1/3 of the patients have to be revised and change some of the components. So as a message, first I have to manage the patient's expectations. It seems a stupid truth, but I have to tell the patients that there is a possibility of up to 15% or more to have transient incontinence, and to less than 1% of having a transient incontinence. But the message is that it is not zero. The emergency incontinence, we know this. We have to understand that everybody has complication, offer conservative treatment, and probably it's enough. But if we have persistent incontinence, we have a urologist colleague to treat the patient, because there are very effective treatments to give back the smile to the patient. And as a colleague says, if you wash dishes, you'll break dishes. And if you are learning, even more so. So these are learning curves. This has been discussed at length. And we have more probabilities of incontinence, more complications, and longer surgeries. Thank you.
Hola. Bueno, muchísimas gracias a los dos por tan
Thanks to both of you for your excellent talks. I don't know if there is any talk from the floor, a question from the floor. I have one for Dr. Sanchez. Of course, both of you can answer about, these tips to prevent incontinence. The tips we saw were anatomical or intra-op, and I wanted to ask if there is any patient profile in which you decide to ask for a functional test. I consider that the right indication helps us manage expectations. I think that an obese patient, an elderly patient, or a very young patient that we are going to take for one of these surgeries, we need a urodynamics test and prevent or know forecast success or failure. We don't get a urometry in all patients, but a urodynamic test to see how the sphincter and the bladder are, we get generally from patients with risk factors or the elderly patient who has high expectations about continence. That would be the ideal patient for a study, and check that the sphincter closes well, and probably they will need a therapy before and after. The surgery and even physical therapy. The symptoms profile, do you take into account beyond the risks? Get a urodynamic test to corroborate that there is a hyperactive detrusor. We should try and differentiate in the IPSS the symptoms that prevail. But it's very difficult according to all the patients when they get to the office, because if we are men, we come with a woman, a wife or whatever, then they are sort of forced to come to the office, but according to their words, they urinate well. So it's very difficult, or at least in my clinical practice, it's very difficult to get the information. I mean, the information I get is very subjective. It would be good to try and provide objective symptoms, but the access to urodynamics is not so easy where in my place. I work in a private hospital, maybe in a public institution it might be easier, but if I ask a lab, ultrasound, and an MRI plus urodynamic test, it will be costly from a financial perspective. And how far does the management of a general urologist get? What happens when you operated on a patient and they leak? It depends on the healthcare system. The patient has, you have social security, you have prepaid medicine, and private patients as such. If the patient doesn't have access to a private insurance, that they get annual checkups, those are the patients in which we won't detect easily a surgical indication. So the general practitioner finds it very easy to indicate blockers. In the public institution, it's also a very common practice. If we don't see an absolute indication, what we do is to indicate that and then have them come back after 6 months or 1 year. So those are the ones that have less access to a timely detection or treatment. Thanks for your presentation. In the decision tree that you have, and depending the degree of incontinence of the patient, should we include the fixation system that we are using? I mean, is there a difference with regards to the degree of continence we can manage in a retropubic or transobturator sling? Decide between a Remex and the atoms, which is transobturator, and both systems are adjustable. The degree of incontinence has to do too. Once we make the decision to use an adjustable system, then probably the incontinence is intermediate to severe, and in this scenario we cannot compare one to the other. But the truth is that any of the adjustable mechanism is good for any of those scenarios. This has to do with the surgeon's preference and the availability. With Atom, I have an experience, and Remix and Vulco, Dr. Gonzalez can discuss. Maybe the technical aspect is important. First, as was mentioned, you have to accept the problem. I think that is the important, not say zero, as generally they say, that they have zero incontinence, and that's not true. Well, I work with them. First, accept when the patient accepts that they can remain incontinent after the procedure, that's one thing. And then you have to consider the patient's desire. Why would I choose any of the methods? In the fixed slings, we have placed many, but it fails quite a bit in the medium or long term. So except in very specific cases, I prefer readjustable. Do I use an Atos or Vulco or the other one? Well, the first thing is the pain, first perineal pain, and that is important because if the guy works with a motorcycle, and he'll have to change his profession. Secondly, the physique, because it depends on the patient whether the patient is obese, and the body tensor, the Remex. The possible complication is the infection, and in a huge in a huge belly, well, it's important to consider that. If incontinence is mild or moderate, I think that with the transobturator is good if it is adjustable. What is the idea of Vulco that is retropubic and is inflatable, that you can treat, as Francisco said, for any patient, the one who doesn't have a manual skill or doesn't remember that they have a device, for any type of incontinence, you can adjust this more or less with the clarification that we are going to get into the retropubis and a patient with infections, intestinal infections. You have to be careful, or morbidly obese patient, and you have to tell them that they will have a pain for 3 or 4 weeks because they have a sort of a device in there in the perineum.
Mudos. ¿Alguien más tiene una pregunta en
Any question? Any other question from the floor? Well, there is no incontinence in the hall because you shouldn't discuss these things. So thank you all. And Dr. Ameri, the head of the service at the German hospital, Dr. Vitaliano, the co-director, Dr. Contreras, the director, all the residents.
Bueno, muy bien. Hemos llegado
Well,
al final.
we have reached the end of a good meeting. The thanks have already been given. So, as we said, this is a theater play, a drama, where you have people in the backstage, you don't see them, but their roles have been important. The technical people, the staff of the hotel, and also the interpreters that we haven't seen them, but they have had a difficult task. So thank you very much to the interpreters. So on behalf of the urology service of the German hospital and the German hospital that gave us this opportunity, we want to thank them all, and let's hope that we met your expectations, and we will see you again for a new event. And even if it is just as this one, it'll be enough, but we'll try to have a better one. So thank you all very much. Now, the final closure will be in charge of Holger. He will close the meeting. Thank you.
Bueno, muchas gracias. Primero de todo, me encontré aquí.
Well, thank you all. It's been good to meet you all. It reminded me of a time 22 years ago I spent at the German hospital. So I want to thank everybody, the organizers of the German hospital, and the people who are not seen all the time, but whose work is very important. And when we organized this event, I spoke with Pablo, and we decided that besides this, the presentation yesterday of a presentation in Instagram, and the best thing I can do, yesterday I did nothing, but I spoke. So I like more to teach things, not to speak so much. And when I prepared that post, I hadn't been in contact with Pablo too much, but I asked him if he could send me pictures or things on the 7 meetings we have already had. And I realized how glorious those 7 years have been.
Detalle parroquial,
Some
14:30.
housekeeping rules, 2:30. We will meet downstairs for the tour. See you next year. Pleasure having you here. This is your home. Thanks.